recap. Sorry.
No worries. All right, everybody. So we're going to kind of pick up where we left off last week. We were in the midst of going over airway management. So we'll do just a little bit of review before we get into the new stuff. And then I think, Chris, you said you're going to do some medical legal also.
Yeah.
Great. So again, I'm going to bring us back, try to always start one of our lectures with just the discussion of my idea of the human home. So remember, as EMTs, we're just kind of repair people. If something goes wrong that we know how to fix, we patch it, we clear the plugs, we flush the leaks or whatever, and we are there to help that person. Our body essentially can be boiled down in a simple way to parts of a house. So with airway management, we're really talking about that air system. So the vents, the trachea, where the air actually goes in, to kind of just, the ventilation system of our body, our lungs, where we get all of that nutrients that we need, like oxygen. So like I said before, we as EMTs really focus on the airway as a two-part system, the upper and the lower. That upper airway we are playing a lot with. We have plenty of things, which we'll talk about in a little bit, that go into the upper airway. A lot of our assessments will be involved in the upper airway as well. This is part of the job as an EMT, where we're actually going to be in there. We've got tools that actually go into the upper airway, whereas the lower airway is kind of more of this metabolic idea. We're trying to figure out, are they diffusing oxygen through their blood? Is there an issue there? That kind of stuff. And it's going to make the difference between what we can do and what we can't. So the structures of the upper airway here that we really want to focus on, it's the nasal passage, the nose into the sinuses. We've got the oral passage, the mouth with the tongue, and that leads back into the pharynx. The epiglottis is that flap of cartilage and skin that goes over the trachea and moves essentially when we swallow versus when we breathe in, to let food down our esophagus, and also just to let air go down our trachea. And we don't want to mix those two up, but it does malfunction sometimes. So we've got that epiglottis right there. And that covers the first part of our trachea, which is our larynx, also known as the vocal cords, and our esophagus, followed by just the structure of the trachea, which is essentially where our Adam's apple sits. And it's the main structure for air to go down into our lungs where it needs to be. Here is a real image of it from the side. Again, just highlighting, these are the structures you really want to know in the upper airway. These will play a big part. The lower airway is the actual lungs that sit there. They expand and contract along with the diaphragm as we increase pressure going in, so that we can take air in, from which we extract the oxygen through our alveoli into our bloodstream, where it transfers carbon dioxide back and we breathe that out, right? So these are pretty important. The structures you really want to know here are the bronchi, which are the tubes, the physical airway tubes that the air can go through, help expand those lungs, and then also the alveoli down at the bottom of those bronchi, which are where the actual transition of oxygen happens. So the main structures here are that trachea. Again, it descends into the lungs. We've got the lungs themselves, the two different sides, one with 3 lobes that would be on the left, and then one with, the right, and then one with 2 lobes that would be on the left. Here's just that fun video of lungs actually expanding. So that's what happens every time we take a deep breath. And if something stops that from happening, it can lead to a lot of bad things. So if you don't remember what a dome is, here's my funny joke that I like to tell about famous domes. With the diaphragm, remember, this is the muscle that plays a huge part in our respiration. When we take a deep breath in, it's not just our lungs expanding, because if the inside of our thoracic cavity didn't change, then we wouldn't be able to take a deep breath in. So every time we're taking a deep breath in, we're really controlling this muscle, the diaphragm. It constantly at rest sits up against our lungs, and it makes our thoracic cavity small. And then when we take a deep breath in, it moves down away from our lungs, increasing the size of that cavity so that those lungs can actually expand. So this is also plays a huge part in our respiration and our breathing, because if there's something wrong with that diaphragm, we can't get a deep breath in, and or we can't let one out. So it's very important. And it's also kind of what spasms when we have hiccups, which is kind of fun. So again, inspiration is just the fancy word for inhalation. Breathing in, that's when our diaphragm moves down, our lungs expand. And then to exhale or expiration, we're going to have that muscle come back and we're going to force that air out. We're going to just touch upon the physiology again. Remember, we're breathing in a certain percentage of oxygen from room air, and that is being transferred to our bloodstream. And then we're getting some carbon dioxide from our body, which happens just doing cellular respiration, and we exhale that. This is very important. If we're not getting enough oxygen in, that can lead to a lot of different things. And it can happen for a multitude of different reasons. Is there something physically blocking the air from getting in? Or is our body malfunctioning? Is something causing the oxygen to not actually get diffused into the body? Or carbon dioxide not getting diffused out? Anything along those lines. And then this is the topic that kind of leads us along something very practical for us as EMTs. We have to do the discussion about respiration and then ventilation, right? We need to consider these two different things because for our purposes, we can help one really well and we can only kind of see and potentially help the other one equally as well. So respiration is that metabolic idea. It's that very small down to the molecules, the oxygen diffusing into the body, into the blood, giving us the oxygenation that we need. So that's that respiration. Happens at the cellular level, down in the lungs, in the alveoli. But ventilation is that physical idea of air moving into our body, expanding our lungs, physically being able to get there. So there is a difference between somebody who would be having a respiration issue versus somebody who would be having a ventilatory issue. So I use this example. We've got our ventilation, which is mechanic. We think of it like a pump. We think of it as blowing up a balloon and letting that balloon exhale that air. And whereas that respiration is metabolic, it's down at that chemical level, we're actually getting the oxygen that we need versus not. Right. So for our purposes as EMTs trying to help people with these issues, a ventilatory issue, somebody not breathing, means that we can breathe for them with a device like a bag valve mask, which we'll talk a little bit about later. And then if somebody's having a respiratory issue, depending on what is causing it, we might be able to help out with either assisting them with their inhaler, giving them a nebulizer of a medication we call albuterol, or even just as simple as giving them some oxygen, right? It depends on what's going on. So this is a huge part of airway management for EMTs. This is the whole kind of theory behind it. If somebody's having difficulty breathing, is it a ventilatory issue versus is it a respiratory issue? So for example, somebody who is having an airway obstruction, right? Something that blocks their airway. That is a physical, it's a mechanical disruption of their ability to breathe versus somebody who has some sort of, chronic bronchitis or emphysema where there's a damage down to their alveoli. There's either fluid or mucus, that's coating those layers so that the oxygen can actually get through, or the physical structure of that alveoli, it's damaged to the point where it's not actually able to transfer oxygen and carbon dioxide as much as we want. So with the normal breathing rates, we touched on this in lab as well, right? Adults, standard breathing, 12 to 20 breaths per minute. So we're going to count how many breaths we get in a roughly 30-second, 15-second time period and do the math to get it up to 1 minute, right? So we're looking for between 12 and 20. We tend to say danger zones for adults is if they are breathing faster than 35 breaths per minute or slower than 8 breaths per minute. And one of the things we say is less than 8, ventilate. So back to that ventilatory idea. If they're not breathing well enough, they're not getting that ventilation, we can do it for them. Now in our next couple of lectures, especially our next one is going to be anatomy and physiology, we are going to start talking more about medical terminology, which is pretty important. You are going to see this and run into it a lot through your career as an EMT. It's important to know it. It's also very important for testing. They're not going to ask you, okay, what breathes slow, right? They're going to say a patient has bradypnea, what's going on? They're not going to play it easy on you. So just keep that in mind. These prefixes, you'll get very familiar with them. So that tachy means fast, that pnea means breath, and brady means slow. So together, tachypnea means fast breathing. That would be somebody who is above 20 breaths per minute. And in bradypnea, anybody who is breathing slower than normal, so anything less than 12. So again, this is going to play a lot on our ability to assess somebody. And difficulty breathing, honestly, is one of the more easy conditions to discover. It's pretty easy to tell when someone is not breathing adequately. One, they're going to be struggling, and they might have some anxiety. That might be a little bit agitated. They might be blue around the lips, right? And we're going to see, we can tell when somebody's breathing adequately. It's pretty easy. So we're going to see a regular rise and fall of their chest. We're going to see a normal breathing pattern, just in and out. We're not going to hear any abnormal sounds. We're not going to see any abnormal sights. All their normal muscles are going to be working. But if somebody's having a really hard time breathing, we're going to be able to tell pretty quickly, pretty much looking at the opposites of what tells us that somebody is breathing well. From what we talked about a little bit, oh, I already put it up here. Never mind. So tripod position is definitely one of those things we'd see somebody physically leaning forward, resting their hands on their knees. If they're sitting down, that's just a pretty natural way for a human to say, I need a little bit of help breathing. Happens to anybody who runs for a while, right? It's pretty common for somebody just to get down on their hands and knees or put their hands on their knees to breathe a little bit better. We're also going to see that bluish tinge called cyanosis, tells us that they're hypoxic around their lips, or their fingertips, their nail beds, that kind of stuff. That's a really good indication that they don't have enough oxygen. Pallor, being pale too, that's really good. And then retractions of those muscles in the ribs. We'll see that video in just a second, but that's a really good sign that they're having a very hard time breathing. The other ones are abnormal breathing patterns. So we've got our Kussmaul breathing, that really fast, really deep abnormal breathing, and Cheyne-Stokes breathing, which is periods of really fast breathing, followed by not breathing at all, followed by really fast breathing, kind of going in and out like that. That's a very good indication of a head injury, potentially a stroke or something like that. Then some other patterns that we'll likely recognize here is, I didn't put this on those patterns, but agonal gasps, just like that video I showed you, I think the exact last thing we talked about in class last time. That's an indication that somebody is in cardiac arrest. It's the brainstem's last ditch effort to get the body breathing when the heart has stopped. So we talked about this all again, too fast or too slow. Obviously, they're going to have labored breathing. It's pretty easy to tell. Their skin's going to be pale. They're going to be cool and clammy, potentially diaphoretic, and they're going to be positioning in a way that can tell you that they're not breathing very well. Here's that cyanosis. And here's that tripod position. So here are the retractions again. So you can see the inside of them, the ribs, the muscles on the inside there are physically squeezing and contracting those ribs to get the lungs to deflate again and even inflate. So this only happens when somebody has been in respiratory distress for a really long time. And this is a really good indication that they're actually going into respiratory failure. When we start seeing systems of the body that don't usually work or come into play for standard life, that's a really good indication that the body is in its last ditch efforts and its last abilities to get you to breathe. So somebody with retractions, that tells you they're in severe distress. So then we'll watch these agonal gasps again, because again, I just think this video is very good. This guy's a fantastic actor. So again, this isn't an instance where somebody would be in cardiac arrest. Their heart is not beating. They are clinically dead, but their body is exhibiting signs that might be construed as life. So just keep that in mind. This is a sign of death. Okay, and now we are on to new things. Does anyone have any questions about what I just reviewed? I know we went over it last time, so I did it pretty quickly, but if you have any questions, feel free to interrupt. Otherwise, we will just continue. Awesome. So we've talked about the physical acts of either not breathing well enough or not being able to breathe, right? Not being able to transfer that oxygen. So this term hypoxia is a broad term for any time that somebody does not have the oxygen percentage that they need in their body. So it can be due to either ventilatory or respiratory issues. It is just a broad arching term for any time somebody does not have the necessary oxygen in their blood. So anytime somebody is either not breathing or they're having difficulty breathing, if it is affecting the amount of oxygen that they are diffusing into their body, they are hypoxic. Now, this condition doesn't necessarily come with any major changes that we can see in our patient. It is possible, and it's definitely happened, that somebody who is not having an apparent difficulty breathing, but is having a respiratory issue, their oxygen is not being diffused. And what this can do is it actually makes people pretty aggressive. Imagine if you were having really difficulty breathing, you weren't getting that oxygen, and somebody's asking you all these questions, right? You're going to snap at them. It's just going to kind of be natural. Your body doesn't have the capacity to breathe. And what do people usually recommend? If you're getting anxious, you're getting agitated, it's always, hey, take a deep breath, right? But if you don't have the capacity to get oxygen in your body, taking a deep breath isn't going to help, right? So one of the things we kind of say is, unless we can assure that our patient has a good blood sugar, is not intoxicated, and they have enough oxygen in their body, they're not an asshole. They're not. Until they get one of those things in their body. So if they don't have enough oxygen in their blood, they're probably going to be a jerk. And that's okay. We can't take it personally. We just register, hey, oh man, this guy's getting mad at me. I can't necessarily see what's going on. Maybe he's hypoxic. We should check his SpO2. Let's check to see if he's got some cyanosis. Maybe he has an injury. Maybe he's got a sickness that is blocking his ability to transfer oxygen. Okay, so hypoxia is that broad arching idea that low oxygen levels in the body can change somebody's behavior. It can also just, really affect their health. Definitely going to need to get some oxygen. So that being said, this is where we as EMTs might actually be able to do something about it, right? So in lab on Saturday, we were talking about trauma assessments, and we were also talking about medical assessments. This is where we're going to open that airway. We briefly touched on ABCs in lab, and then we also touched on it last time in class. So airway, breathing, and circulation. In order for us to effectively manage somebody's airway, we need to be able to open it appropriately and see what's going on. So we actually have two different methods that we use to open airways. The first one is called the head tilt chin lift version. So this is something definitely you guys are going to want to remember and write down. We're going to talk a lot about airway managing maneuvers. So the important thing about this is that what we're doing here is we are actually positioning that person's airway, their trachea in their mouth, nose, and throat into a more straight line, right? When we lay down naturally, our airway kind of curves at the back of our throat there, just by how our anatomy works. It's totally fine that it does that. But if somebody is in a really bad way, right, they're unresponsive, they're unconscious, they're sick, they might not be able to manage their airway effectively like we can if we are not sick. When you sleep, you're relatively able to manage your airway unless you have something like sleep apnea, which is just kind of, set against you based on like what anatomy you have. But for the most part, we can sleep and we can still breathe without it being an issue with our standard anatomy. However, if somebody is really sick, if they're overdosing on something, if they've got just really bad health at this moment, they might not be able to manage that airway, even just laying on their back. So one of the reasons we do this is to open their airway into essentially a straight line for a couple of different reasons. To alleviate any blockages that might be there based off of their own body. So the tongue occluding the back of their airway, you might hear some snoring sounds. And doing this maneuver, the head tilt chin lift, will actually alleviate snoring. It also allows us to kind of get a better visualization of their palate and their throat. So if we are doing the head tilt chin lift and we open their mouth, we'll actually be able to see further down into their trachea than we would be if we just open their mouth without doing a head tilt chin lift. So this is really good for assessment. If we need to suction somebody's airway, if there's vomit, blood, or whatever else in there, we can see a little bit further. It's also just a really good way, very quick way of opening and assessing the airway. Now, what patients should we not use this method on, and why?
Ones that are suspected of a C-spine injury, to prevent further injury to their spine.
Yeah, exactly. Because of how this works, right? We are physically tilting somebody's head back. And if they have any sort of injury to that C-spine, the part of our body that keeps us alive, really the autonomic function center. If we are concerned there's an injury there, we don't want to move it whatsoever or as little as possible. So if we're going to do this head tilt chin lift, we're essentially moving it. That's it. We're only really moving the C-spine. So the head tilt chin lift is only for patients who we determine to be non-traumatic patients. So this is really important for patients who are in medical induced comas. So things like hypoglycemia, hyperglycemia, overdoses on pretty much any sort of medication that will make you unresponsive. Anytime somebody loses consciousness and they are not, and it's not due to a traumatic injury like getting hit or something like that, that's when we can use the head tilt chin lift. So we're going to use these in majority medical instances. Now, the maneuver that we do use for trauma is called a modified jaw thrust. So what we're going to do here, and the reason that we do it this way is because it's going to not move their C-spine at all, and it's just kind of affecting their jaw, and it's physically lifting off that back of our throat, lifting the pressure off of there. So the goal here is essentially to give your patient an underbite. So you're going to find that kind of L of the jaw, and you're just going to simply push forward. You're not going to pull. You're not going to, really try to crank it or anything like that. But the goal is to push it back so that it takes the pressure off the back of their throat. Now, that being said, if you do it on yourself, what's something we might want to consider with this?
Jaw injuries.
Yeah, if somebody's got a jaw injury, if we're doing this for trauma patients, that could be an issue. What else? Personally, I just think this hurts. If you've ever had someone do that to you, if you weren't expecting it or anything like that, it kind of hurts. And we also don't want to do it too strong or anything like that. We don't want to hurt our patient, but this is a really good way to open their airway. The main thing that I'm thinking of here is that if somebody is totally unresponsive, even if we move their airway open, what happens as soon as we let go? It goes right back to where it was before. So if they had an obstruction or if anything else was going on, if we do this and then we let go, we've just put their airway back into mismanagement. So one of the things about the jaw thrust is to do an effective jaw thrust, it needs to be held until something can keep that airway open. So just putting your hands on the patient and going like this is not enough to open the airway. You have to hold it like that. You are physically holding that person's airway open because they are not able to manage it themselves. That makes sense? They're going to be flopping everywhere. They're not going to be able to hold their jaw open, especially if we need to.
Kevin, I think we
Kevin,
lost
we can't hear
audio.
you. Now we hear you.
You do?
Mhm.
Give me a sec. Okay, that was weird. Don't know what happened. Sorry about that. Okay, we're back. So holding that open, very important, unless we can do something to keep it open, okay? A main reason of why we're going to be opening someone's airway in the first place is because they're not able to manage it. So one of the tools that we have to help manage an airway is a portable vacuum cleaner. Essentially, it is a suctioning device. We have multiple kinds. There is a manual one that's pretty much out of, pre-battery times. We've got ones that are built into the truck. So we've got an internal suction system here. And then we also have a portable one that we can pick up and bring with us. These are really great. We use these quite frequently. So the idea here is if there is a liquid or if there's really anything that is in the airway that we don't want there, we can get it out to a point, right? We're not going to use this to try to clear somebody's completely obstructed airway from a piece of steak way down here. One of the main rules is that we're only going to suction as far as we can see. So therefore, using a nice head tilt chin lift, we might be able to see a little bit farther and suction a little bit better. But for the most part, we're really only going into the mouth and suctioning anything out of there. So the main things we're really thinking about here, it's going to be vomit. It's going to be blood. Another thing to consider is that depending on the level of trauma, you might be sucking things out that are part of somebody's body. Flesh, personally, using one of these portable suctions, you can suck out teeth. Believe me, it works. You might have to clear it, but it takes out big chunks of things. So these are really important. If somebody is vomiting and they're not able to control their airway, or there is something in their airway, one of the first things we're going to do is clear it. So remember, the idea of those ABCs, those airway, breathing, and circulation, we're trying to find something that is going to tell us that this patient is in a bad way, that they're going to die in the next 5 minutes. If there is something wrong with their airway, breathing, or circulation, we're going to try to fix it right then and there. So if we show up and somebody has something in their mouth, like liquid, vomit, blood, whatever it is, one of the first things we're going to do is clear that airway as best as we can, suction it out. So on a lot of calls, a lot of cardiac arrests, a lot of trauma calls, suction should be one of those main things we try to bring into the scene with us.
Hey, Kevin.
Yeah.
Can you see into the mouth as well when you do the jaw thrust, or is it limited based on position?
It's limited because you're kind of pushing that back of the jaw forward and not opening the mouth as much and not kind of giving it more space. You can't visualize further down into the airway. For the most part, though, we don't, as EMTs, we don't need to see that far down. It just kind of help us with our assessments. You can just as easily suction with the jaw thrust, because we're going to be doing something similar to what we see in the picture here. We're going to use that jaw thrust to open the airway and look inside. And if we see something, we're really just going to kind of open that mouth without moving their C-spine to suction and then go back to holding that jaw thrust. Okay. So how we're going to suction is we're going to visualize the airway. We're going to open it. We're going to suction or turn our suction on, and we're going to insert our rigid catheter into their mouth. As you can see in this picture, or hopefully you can see, this person's thumb is covering a port in that suction catheter, and them covering that makes the suction actually come at the bottom of the rigid catheter inside the mouth. So one of the first things we want to do is we're going to insert the catheter without covering that hole, without initiating the suction into the catheter to begin. That's just to reduce the chances of us getting their lips or something like that on our way in, their tongue. So we insert the catheter without clamping down to give suction. Once our suction is in there, that is when we are going to close the hole, and we're going to suction in a circular motion on the way out. And we're only inserting it as far as we can see. Okay. Also, we don't want to suction for any longer than 15 seconds. Why would that be?
It impedes breathing?
Yeah. A vacuum cleaner's job is to remove air quickly from that area. So if we are suctioning someone's airway, we are effectively stopping their ability to breathe, or we're stopping somebody's, if we are giving them bag valve mask respirations, we are going to be having to stop doing that to suction. So we want to minimize the amount of time that we're doing this. However, if somebody's airway is really blocked, we don't want to force that down with any BVMs, right? So we do want to have blow-by oxygen here. We want to take our time, suction for those 15 seconds. If you need to do it again, give some oxygen and then suction again. A tip that I have for this that I think helps, rather than, setting a timer and getting down there to suction for exactly 15 seconds, is when you begin suctioning a patient, just hold your breath, because then you're going to start to feel the anxiousness of not having enough oxygen in your body. And so when you start to be like, oh boy, this is ridiculous, you're going to register, oh wow, that's what my patient is feeling too. Especially if we're nervous and suctioning somebody with this, it's going to be less than 15 seconds. Our main goal is to remove anything that would be blocking it, or just get that liquid or whatever it is out of there. So no more than 15 seconds. And another main point here is, remember, don't cover that suction hole until we get into the mouth, then initiate suction in circular motions and take it out. Any questions about that? We have plenty of time in labs. We're going to have hands-on use of these things so you guys can get familiar with it. Cool. Now we get to talk about a fun thing that you guys can do. These are airway adjuncts. So these are some of the pieces of equipment that we have that we actually insert into somebody's body. So I'd say that these are some of the more invasive things that you guys can do. We are physically inserting devices into somebody's mouth and or nose. And so these are important things to know. But these are also really important tools. These can drastically help somebody or change somebody's situation. So we have two different types. The first one is called an oropharyngeal airway. We call them OPAs for short. But essentially, if you remember from the beginning of this presentation, the airway anatomy, we've got our oral passage, our nasal passage, and then the pharynx sits right at the back, right? So this is an oropharyngeal airway. It talks about the oral cavity into the pharynx area, right? That's where the name comes from. So there are a bunch of different sizes for them. They range from itty bitty small for infants up to, large adult sizes. These are the preferred airways for EMT basics. I put quotations around because they are the preferred method. They do multiple things, but they are relatively rare in the fact that our patient will accept them. What it does is it provides a pathway of air from the front of their mouth. It's a designated tube, right? It goes past their tongue down to the beginning of their airway. So the goal here is if somebody's unconscious and they're not able to manage their own airway, we can insert one of these into their mouth down into their throat. And when we give bag valve mask ventilations, the air is going to be helped along past their mouth down closer to the beginning of their airway. The cool thing about this is one of the main obstructions of the airway is just the tongue. And so people who are unconscious due to whatever reason, their tongue oftentimes blocks their airway. So if somebody is just laying on their back, completely unresponsive, we're likely going to hear snoring respirations, which tells us that there is an issue, that there's a blockage. So what this device does is it actually molds as best as it can around the tongue to keep it forward, to keep it from falling backwards. So that's part of what the shape is. You can see that it's got that curve there. That's supposed to go over the tongue and then also rest right at the back. So that keeps that tongue forward. So an appropriately placed OPA should actually keep the airway open, and it will stop the tongue from becoming an obstruction. So that's why it's the preferred reason, because it does two things versus the NPA, which just does one. Now, what might make you say, okay, I should not put this into a person?
If they start gagging.
Yeah, right. The gag reflex is a very strong part, a reflex in our body. And a lot of times, even people who are really close to death, whether it's due to trauma or a medical issue, still have an intact gag reflex. So if we're trying to put this in somebody and they start rejecting it, they start making gagging sounds, they look like they're about to vomit, they physically withdraw from you due to this, we can't use it. Because if we continue to do that, if we cause them to vomit, then we have just created a bigger issue than we want, right? We are putting this in there to keep their airway open. And if we force them to take it and they're not accepting it, their gag reflex is going off, then we have created a problem. We have obstructed their airway. Okay. So the main reasons we're not going to insert this is if they don't accept it. If they're conscious, they won't accept it. They don't need it. We're really using this on people who are unresponsive, people who cannot manage their own airway. This isn't good for somebody who's just sitting here having difficulty breathing. This is only good for somebody who is not breathing well enough and they're not able to manage their own airway. Other reasons we're not going to insert this is really bad facial trauma, right? If there's anything wrong with the mouth, we're not really going to be able to get this in. This kind of ring at the base here or at the top, that's supposed to sit on the teeth. So the teeth are that landmark to keep it there. So if somebody doesn't have, if it's a lot of trauma or something like that, it's not going to work. We'd risk actually creating an airway obstruction by putting this in because it could slide back. It'd be an issue. Now, if this OPA doesn't work, if they don't accept it, if they're gagging or if they're coughing or something along those lines, but we really think that they need an airway, our next tool here, here's actually a better image of it going down to the throat for you guys to visualize. Sorry. So it goes into the mouth, protects that tongue, keeps it in, gets right to just above, the epiglottis, and so it can hopefully push air closer down. Now, if they don't, yeah.
So I know there's different sizes. I've seen them before. How do you know what size to use on an adult? Because there are different sizes.
Nope, great. It's on my slide. I should have mentioned it. So the way that we size this is from the corner of the mouth to that angle of the jaw. So we take whatever size we have, we're going to line that tip right up with the corner of the mouth, and then that should go right to about to the corner of their jaw. So what we'll do is we'll just pick it up, we'll hold it to the corner of their mouth, and if it lines up roughly with that side of the jaw, that's the appropriate size. It's not a 100% foolproof way of sizing it, so we just might have to attempt one. If our patient gags, we might be able to go to a smaller one, but really if they're gagging, it's probably not going to work. We just want to make sure that we kind of err on the side of short rather than long, because if it's too long, it's going to cause potential damage and it could make them gag. And if it's too short, it has a potential to work, but it might not be effective. So we go to that corner of the mouth to the edge of the jaw. That's how we size it. And when you get these, I mean, they're all pre-packaged. They're not reusable. So if you use this on a patient, don't dip it in sterile water and put it back in your kit, throw it out. They all come pre-packaged. It's usually just in a bag. So you might have to go through a couple, especially depending on the scene, to see which one is the appropriate one. However many you need to size, that's totally fine. Just put in the one that fits the best. So if that doesn't work, then we have what we call an NPA, a nasopharyngeal airway. It's a little bit longer, less rigid, because it does need to conform to our sinuses, to our nasal passage, and it goes into the nose and to around roughly the same part of the throat. This one is less likely to be rejected by the patient because it doesn't have such a strong play on their gag reflex. It is quite uncomfortable, and quite uncomfortable, if I do say so myself, but it also works. So if somebody is really unresponsive, they will take this much easier than an OPA. Out of all the times that I've used an airway, like a basic airway, my patients have always accepted an MPA, hardly ever accepted an OPA. It's a much stronger reflex, the gag reflex, than something going up our nose. So the way that we size this is we're going to take that tip of it, that flared tip, and we're going to put it down to the lobe of the ear. So on the same side, this one goes to the lobe of the ear from the corner of the nose, not the corner of the mouth. Nose to earlobe for nasopharyngeal, mouth to jaw for OPA.
Have you ever used one of these on a responsive patient?
Not really. I saw Chris laugh. So you can, but it's not really necessary. If somebody is conscious and they're having difficulty breathing, there are far better ways than giving them an airway. These airway devices are really for people who cannot manage their own airway. They're unresponsive. You'll see why in a minute, but this is people who are conscious aren't really going to accept this willingly. It does hurt quite a bit, but it's not the same like level of a gag reflex. Like once you put it in, it kind of sits there and you get over it. But with that gag reflex, it's just constantly making them want to vomit. So it is a little bit different. Conscious patients, we should be using breathing techniques. We should be using oxygen or other medications that we have to try to help them breathe. Conscious patients usually don't want to accept these or benefit from them. I think one of the reasons we were laughing is that this is a really good way to test responsiveness. If somebody isn't, or if you suspect that somebody's faking, one of the good ways to assess responsiveness is, hey, they really need an OPA. And you start to insert it and they'll immediately start slapping away. It's a pretty good reason to say, okay, you're not actually unresponsive. But yeah, people who are conscious don't really accept these. Unless,
I actually have a question.
Yeah.
Also about sizing, I think it showed in the photo as the oropharyngeal airway. Is it nose to lower earlobe?
So the
No,
nasal,
not about the nasal as it shows in the photo there.
Yep. So nose to earlobe, whereas the OPA is that corner of the mouth to jaw. That cleared up?
Yeah.
Okay. So that's how it kind of sits. I'd say that this is way too long. It does not go past the epiglottis. So here we go. This is what I mean. See if you recognize this guy. So that was me back in the day taking an MPA. It really hurts. It's not fun. That took a lot of restraint for me not to be crying out and gagging. Okay, so a conscious patient won't really accept it. There was a bunch of surgical lube on there, but still, it hurt really bad. Your nose is not that wide past your nasal cavity right here, and it really just kind of gets forced down in there. It's not a fun time. So another thing I want to talk about with the NPA is that the right nostril is actually preferred, because all of these are designed specifically for the right nostril. I don't know if you guys can see in the picture here, they have a bevel, kind of like a needle, right? So one side is just a couple millimeters longer than the other. And the reason behind that is it's designed to follow the right nasal passageway. So it's bent in that passageway, or it's kind of molded to have that little bit of a bend. And then the reason that we want to put the bevel to the inside, you're putting it towards the septum as it goes in, is because when it goes down, if it's flipped, we're going to have that bezel of the airway against the wall of the nasal passageway or the throat. So when we push air into it, it's going to be fighting against the wall versus pushing air right out into the passageway. So we want to lubricate the distal tip of this with surgical lube, and then we want to put the bevel to the septum side in, and then that's how we're going to insert it. Now, that doesn't mean that we have to do it that way. If somebody has a, like a deviated septum, if there is an issue where you can't actually insert it into the right nostril, you can just flip it to the other side. But the main thing is we want to keep the bevel in. So it will, actually, you're going to essentially be inserting it against the curve of the throat, but that's okay. But we still right nostril first. And if something is wrong with that nostril, you can insert it, then you can go to the left side. We just don't want to start on that left side because it's not preferred. It's not what the device is made for. That makes sense?
Kevin, just a quick clarifying question on that.
Yeah.
So the bevel is going to be the longer side, that you're going to have that towards the septum?
The shorter side. So you want the opening against the septum.
All right, thank you.
Yep. And again, we're going to have our hands all over these lab, putting them into anatomically correct mannequins. So we're going to have lots of practice, and I can show you physically why whenever we go over this. But just in lecture, it's hard to explain. But yeah, bevel side into the septum. We don't need to watch this again. Okay. So these airway devices are so that we can insert oxygen into somebody's body if necessary, right? There are plenty of times, and I would say majority of the time, that we are actually giving oxygen, to patients is when they're conscious and when they don't have an NPA or an OPA in. But those times that they're really sick, we're usually providing ventilations for them, and those airways are to help us get air down further. However, there are plenty of times where we're going to manage airways without a physical airway adjunct. And one of the main things that we do, one of the more common medications that we prescribe, is oxygen. What we're trying to do, and the people that we're trying to give oxygen to, are specifically people who are having difficulty breathing, or people who have an oxygen saturation of below 94%. So that SpO2 that we kind of mentioned when we were talking about vital signs, that device that tells us the amount of hemoglobin bound in their blood, hopefully by oxygen, the normal ranges that we want to see is 94 to 100. That's pretty normal. Anything below 94 in a healthy individual tells us they're not getting enough oxygen. So if somebody has a 94 reading, but they're not having difficulty breathing, but you can confirm that it's a reading of 94 or lower, we're going to give them some oxygen. Whereas we're also going to give somebody oxygen if they're having difficulty breathing, but their SpO2 is not below 94, right? We're going to treat some people's symptoms. Oxygen does tend to help people who are having a tough time breathing, but we're also definitely going to give it to somebody who has a SpO2 of below 94%. The other conditions that we really want to give people oxygen for without really even considering their SpO2 reading are people who are in shock, hypoperfusion, which we will definitely talk about another day, or cardiac related chest pain. And both of those things we'll talk about, but those two conditions really require a good amount of oxygen, regardless of what the SpO2 says. Okay. Now, the other thing about oxygen is that we want to be really careful with it. Does anyone know why?
If you drop it, it will shoot off like a rocket.
Yeah, it does definitely have the potential to do that. It is a highly pressurized, very heavy tank. And if this thing at the top gets knocked off, this thing at the bottom becomes a projectile, just like a balloon, right? But much more deadly and scary. It will be like a big bang and it will go flying. Why else?
It's combustible.
Yeah, it is a high pressure tank and it is not combustible per se. It's an accelerant.
It's
It
an
feeds
accelerant.
flames. Yeah, so you're absolutely right. It will make a boom go bigger. It makes fire really happy. Fire burns oxygen. That's what it feeds on. So if there is an open flame and we have an oxygen tank with us, that could be a recipe for disaster. We could make that fire much bigger. So that being said, people who are smoking cigarettes while on home oxygen happens quite frequently. The amount of times I've shown up to somebody who says, I'm having difficulty breathing, to find them sitting on their front porch with their oxygen tank smoking a cigarette, I can't count the amount of times that has happened. And the first thing I always say is, hey, please put that cigarette out while you are on oxygen. It could explode.
I have a question about that.
Yeah.
Say you go onto a scene, say someone's has a campfire, and you're administering oxygen. What's the distance we should be concerned
As far away as possible. So if they're next to a campfire, I don't care. I'm putting them in my ambulance and I'm giving them oxygen there. If there's an open flame, we don't want our oxygen tank near it. We don't want any sort of oxygen leaving that near it.
Perfect.
Over 10 feet away, that's fine. It's not
Yeah.
going to work that strong. It's not going to carry that far, but we don't want to mess with this. We don't want to play with it. If there is an open flame, I'm not bringing my oxygen near it. Okay. Everyone do what my presentation says. Take a deep breath right now. One, that just feels good. It's always nice to take a deep breath. But you also just inhaled 78% nitrogen, 20.9% oxygen, and around 1% other gases. But it's imperative for us that we change that percentage for people who are having difficulty breathing, and especially really critical patients. We want to get them to breathing as close to 100% oxygen as possible. Now, that's almost impossible to do, especially with just masks or BVMs. There's always going to be some leakage from either the outside or we're just putting too much and they're not going to get it 100%. But our goal is really to try to get them to as close as 100% as possible. And we do this through, one, the administration of oxygen itself, but also based on what device we use to administer that oxygen. And a couple different ways that we ensure this is continued monitoring of their SpO2. So after we determine they need oxygen, we can keep it on and we see if it increases. We can also do focused assessments. So looking at their breathing, has it gotten better? Has it increased in severity? We can listen to their lungs using our stethoscope. We can check to see if we can hear air equally going into both sides. We can select the appropriate device to give them oxygen. We're going to give them the appropriate amount of oxygen per minute, liter per minute. And then we're also just going to put it on and use it correctly.
Kevin,
Yes.
quick question. When do we have to worry about oversaturation of oxygen, or do we have to worry about it?
So as a basic EMT, you don't.
Okay.
There is a small chance, and this is pretty debated topic within EMS, is there's something called basically late stage COPD. We have something in our body, and I'll talk about this when we talk about SpO2. So it's a good time. It's called our hypoxic drive. So in that ever so important brain stem, that cervical area, there's a bunch of monitoring happening of our bloodstream. And for people who are healthy, it measures the amount of oxygen in our blood, and that is what makes our breathing rate. So if we have too low of oxygen in our blood, our body says, kick up that breathing rate. If it's too high, it'll slow it down. But people who have, and this is very rare, and it's documented only a couple different times, who have really late stage COPD. So people who have been smoking 2 packs a day since they turned 16. Really bad. They continue to smoke. They are on home oxygen. One of the theories is is that their hypoxic drive switches from registering the amount of oxygen in our blood to measuring the amount of carbon dioxide. Sorry, I flipped that. Healthy people, we measure carbon dioxide in our bloodstream. I'm terribly sorry. And then people who continually breathe it in, they actually measure the amount of oxygen. So the theory here is that somebody who has this late stage COPD, if we were to give them a high amount of oxygen, we would tell their their brainstem that they don't need to breathe. It's like, oh, there's so much oxygen in my blood, I'm good. I can just stop breathing. And so there are some rare documented cases of people with late stage COPD who are on really high amounts of oxygen for a long period of time, just stopping breathing because their body says, we've got too much oxygen. We don't need to breathe. For our purposes, though, it's not really a concern. If somebody is having difficulty breathing, if their SpO2 is lower than their baseline, we should give them oxygen. The times that we see oversaturation is on long term of high flow oxygen over days and days. So for our purposes, from the emergency scene to the hospital, it's not really that big of a deal, but that's a good question.
So you said that you would deliver oxygen if levels were lower than their baseline, or I guess 94. Would there be any reason that somebody would have a baseline below 94
Yeah,
other than
so
COPD?
Yeah, so if people with COPD, we tend to see baselines below 94. So if they're not on oxygen or if they're just at home, it could even be as low as like 88 is their standard. These people are the people that we see constantly on home oxygen. There are plenty of different conditions that could require someone to be on home oxygen, but somebody with COPD will have that baseline lower SpO2. So for them, we're going to go based on of their baseline. So if we say, hey, you've got late stage or you've got COPD, what's your normal SpO2? They're on 2 liters all the time. And they say, oh, my normal on 2 is around 88, right? I'm going to say, great. Your SpO2 is 89 on 2 liters. I'm just going to keep you on that. But if we get there and they say my baseline is 88 on 2 and it's 80 on 2 liters, that's when I'm going to give them more oxygen because they need it. It's not abnormal for them, or it is abnormal for them. Does that help?
If someone were unconscious, how would you make a decision about what SpO2 level to target?
If they're unconscious, we're giving them high flow oxygen.
And you feel like those pulse oximeters are relatively accurate? Like there are a lot of variables, like temperature can affect it, if they have lotion on their hand, if they, aren't there lots of things that can affect how accurate those are?
Yeah, absolutely. But for the most part, these are going to be very helpful, very accurate. These really don't work. It's more so in extreme temperature differences. So like if somebody's hands are so cold that there's barely any blood going through there, or their circulation is that stunted, we might not see it. Usually normal nail polish is relatively okay, but if they've got those really big, thick gel nails, those tend to stop it from working. The main things that we can register with this is that we don't need an SpO2 to tell us that somebody's having difficulty breathing. There are plenty of physical signs, there are plenty of emotional signs, and just ways that somebody presents to tell us that they need oxygen. This is just a really good tool for us to confirm whether or not they need oxygen. And if somebody isn't presenting with difficulty breathing, but we throw the SpO2 on and it says 94 and they have some sort of, their vital signs are wonky, it probably tells us, hey, they need some oxygen. We've mentioned these setbacks so that you can use them and you can make an educated decision on whether or not you think that is coming to play with your patient. For the most part, these work really well. In standard calls, outside of, really environmental things, being outside, being at an active fire, these work really well. And if it's not working, it's not the end of the call. We're not going to be out of luck. We can use all of our other assessment tools to determine what they need. But for the most part, these work really well. One of the first things I will always do is direct someone to put an SpO2 on during a medical call. If I'm talking to somebody, if I have one in my hand, hey, how you doing? Thanks for calling 911. I'm putting this on your finger. It's really good. But that being said, so what an SpO2 monitor actually does is it's using its infrared light, aka magic, to assess the number of seats that are bound on our hemoglobin. So our red blood cells, you can picture them kind of like buses. They've got a whole bunch of different seats, and they go all across our body, dropping off the passengers of those seats to the places that they need to go. What an SpO2 is doing is it is taking quick pictures really fast of our hemoglobin and roughly giving us an idea of how many of those seats are taken, how many of those bus tickets have been sold. We're hoping that those seats are taken by oxygen. But carbon dioxide or carbon monoxide actually binds to hemoglobin like 100 times more potently than oxygen does. So if somebody came out of a burning building and they had just breathed in a bunch of that ash and all that smoke, their SpO2 will say 100% without a doubt, because all of that carbon monoxide has bound onto the hemoglobin, and all this device is doing is just registering how many of those seats are bound. It's not actually determining if it's oxygen or not. So that, regardless if it's a setback, actually tells us something, right? Somebody comes out of a burning building, we put the SpO2 on their finger, says 100%. We know they need oxygen because their hemoglobin is just bound up by that bad stuff, right? So we can use it as kind of a counter assessment. It's not low, but we can tell that it's not reading accurately, so they definitely need some oxygen. That being said, again, I will always recommend the use of this. You should put this pretty much on every single patient. It just gives you a good baseline of what you know. It also registers their pulse too. So after you check their pulse manually for the first time, if that SpO2 is working, you don't see it causing an issue, you can usually get an accurate pulse rate off of this. The times that it won't work for a pulse is if somebody has an irregular pulse rate, like if they have AFib, you'll see that number of pulse go from like 200 to 10 to 30 to 60 to 100 to 0 to 200. So just keep that in mind. Now, based off of how our patient is presenting, based off of their SpO2 reading, this will help us determine how much oxygen do they need. We kind of have two versions of oxygen. It's either not that much or a lot. So we have low flow and high flow oxygen. Pretty much we have one device that gives low flow, which is this one, the nasal cannula, and then two devices that we use for high flow. So this nasal cannula is really only good for 1 to 6 liters per minute through an oxygen tank. However, that being said, we tend to use 2 to 4 liters. 1 liter is not really enough to say that we're giving somebody oxygen, especially in an emergency situation. 1 liter is usually used for people who are at home who just need a little bit of a supplemental help. And then 6 liters per minute on a nasal cannula can actually feel pretty uncomfortable for the patient, because how this works is it's really just 2 prongs that go a little bit into the nose. And so when we crank it up to 6 liters, it kind of feels like somebody is blowing really hard into your nose. It feels cold and somebody's like getting back into your sinuses. So we tend to say 2 to 4 liters per minute works really well with a nasal cannula. So as you can tell, we're not getting this person super close to 100% oxygen. Even though 100% oxygen from the tank is coming through this tube and into the nose, people don't really ever just breathe through their nose, totally, 100%. And even if they did, these cannula prongs, they don't occlude the nostrils, so room air is getting in as well when somebody is breathing, and they're also going to be breathing in through their mouth too. So they're really only getting close to, on a good day, close to 50% oxygen on this. So we're using this for people who we don't think needs a whole bunch of oxygen. They might just need a little bit of help. So for the most part, we're not giving people with, acute breathing issues a nasal cannula. This might be something that we give to somebody who has a known issue like COPD, emphysema, and they're usually on oxygen. We give them a little bit of supplementary. And if they're not usually on oxygen, if they're teetering around 94, but they're not having that much difficulty breathing, I'll give them a nasal cannula, 2 liters, see if that helps. A lot of people have these for home oxygen. And one of the things I always say is that if we're going to either take somebody who has home oxygen in the ambulance, either we leave a nasal cannula there, or we take their home cannula off, give them a new one so that they don't have to go get another one when they come back. Does anyone have any questions? Cool, moving on.
Is there a rule of thumb in terms of SpO2 levels below which you wouldn't use the nasal cannula? Like, is it just for in the low 90s or high 80s or?
It's going to depend for me on how my patient is presenting too. If it's like 93 and they're having normal conversations with me, they say they might feel a little short of breath, but it's not too much, I'm going to give them 2 liters on a nasal cannula. But if they're having difficulty breathing, like it's obvious they're labored breathing, you can hear some abnormal sounds, they're in tripod position. If their SpO2 is 93, I'm going to give them this device, the non-rebreather. It's really depending on their level of difficulty breathing. If somebody's heaving, I'm not going to give them a nasal cannula. But if they're just kind of normal, but they're a little bit hypoxic, I'll give them a nasal cannula. It's just a little bit to help. For the most part, though, we're really kind of more concerned with the patients who need this mask, the non-rebreather, the NRB. You guys should have been exposed to this on Saturday with that oxygen setup station. This is the main thing that we're really trying to give oxygen through. This is high flow oxygen device. It provides very close to 100% oxygen, roughly around 90. So this is one of those best devices we have to get someone a higher concentration of oxygen if they need it. It's called a non-rebreather mask because it has seals and that oxygen reservoir. So when somebody breathes in, the seals close, not letting in any room air, and they take 100% oxygen from that bag into their airway, and that bag is refilled from the tank. So every breath they take, it will be as close to 100% oxygen as possible. And when they exhale, those vents at the top will actually let that air out, so there isn't any cause for room air or that expiration air to go into that 100% oxygen bag. So this is really good. This is a great device. Pretty standard what we're going to use if someone's having difficulty breathing. And this is what we call a high flow oxygen device, and that is 8 to 15 liters per minute. You are going to be saying high flow oxygen, 10 to 15 liters, quite a bit via NRB. So I just start remembering that now. And this is another one of those things that we abbreviate. So non-rebreather mask, or NRB. Now, the next device that we have to provide ventilations is a BVM, a bag valve mask. You can see this person using it here. It essentially looks like a football that has a thingamajig coming off of it that's a mouthpiece, and then it also has a bag at the back. So this is for when somebody is not ventilating, when they're not breathing. So when we squeeze that bag after putting an appropriate seal over their mouth, we squeeze and we are forcing air into their lungs. We're forcing that mechanism to work. We're forcing their diaphragm to contract and expand their thoracic cavity. Now, with this device, we can attach oxygen. So if somebody's truly not breathing, what we're doing is we're giving them 100% oxygen into their lungs. It's roughly the same as that NRB, probably between 90 and 100%, just based off of user error or anything like that. But this is really good. And this is a device that can absolutely, in tandem with appropriate use of it, save somebody's life. If somebody is not breathing, but they still have a pulse, their heart is still beating, and you register that quickly enough, and you begin to give rescue ventilations with a BVM, that person will likely survive. If their heart continues to beat and you continue to breathe for them, it essentially means that you can keep them alive for as long as you have oxygen and you can ventilate them. So a call might mean that you are bagging somebody from where you get them on scene to the hospital, and they don't change at all, but their heart rates continue, or their heart continues to beat. That's great. If you manage their airway and you breathe for them, it might be challenging, right? You're going to have to do a lot of work during that call to keep them alive, but you are physically acting as their ability to breathe. So you can keep that person alive indefinitely, essentially, depending on the other factors. So we use these a lot in opiate overdoses, people who are just apneic, who are not breathing, and very frequently in cardiac arrest situations. This is how we give people ventilations. So if you're ever concerned that a patient is not doing appropriate ventilations and they are unresponsive, this is definitely the first thing that we should go for. It is preferred to be used by 2 people. This is the most effective way to use a BVM. The reason behind that is it's really challenging to keep an appropriate seal on somebody's face like this guy is doing here with his two hands, as well as squeeze the bag. We'll figure this out when we start using mannequins. It does take a lot of dexterity and manipulation of the patient to get a good seal with one hand and give appropriate ventilations with the other. So 2 people is the preferred method. However, 1 person BVM ventilations definitely happens all the time, and it's definitely a very viable way to give someone respirations. We're going to practice majority of the time with a 1-person BVM administration, but keep in mind, if you have that extra hand on scene, it's much more effective to have 2 people do this.
Kevin.
Yeah.
With the bag valve mask, if you're by yourself, are you still better off with a bag valve mask than mouth to mask?
Oh yeah. If you have a BVM and you're on duty, definitely use the BVM. We can do mouth to mask. It's one or the other. You can do either one. I would suggest using a BVM. It doesn't require you to do that. Also, we can't really give high flow oxygen through that mask as well as we can through a BVM. So if you're by yourself, I mean, I keep one of those mouth to masks in my car all the time, just in case. I don't necessarily keep oxygen BVM with me all the time. So it's definitely a viable way, but on duty, use the one that you can attach oxygen to. That's really going to be the best.
What % oxygen are you giving somebody if you're doing mouth to mask? 'Cause it's
0.
Yeah, it's like your exhalation, right?
Yep.
Yeah.
So you're really just with a mouth to mask situation, you're giving them very little oxygen. It's more so to, what's the word I'm looking for? It really kind of stimulates that respiratory drive. So sometimes if people aren't breathing, but their heart is still beating, all they need is a little bit of like a kick to get going. So that physical act of their lungs expanding and contracting and getting some airflow moving will spawn a change. Maybe it'll kick them awake and have them start breathing. So it definitely will work, but without oxygen, we're not actually helping them as much as we want to be.
Wait,
So definitely,
Kevin,
yeah.
I feel like I saw in the book somewhere that expired air is like 10 to 13% still, maybe? Is that,
Yeah,
does
so
anybody else
you-
remember seeing that?
You're accurate. Here, I have a slide back here that I think says it. Way at the beginning, but that's okay. We got time. So expired air contains roughly 16.4% oxygen. So you're giving them a little bit, but it is still less than a normal breath. And if they are truly in a medical emergency, it's not enough to really help them as much as we want.
Got it, thanks.
Yep. Speed clicking. Cool. So we have some indications. We're not going to give BVM ventilations to everybody who has difficulty breathing, right? There are definitely some times where we're going to need to assess to see if this is necessary. Just picture, if you're breathing too fast, say you went for a run, you're having some difficulty breathing, and an EMT shows up and says, you're breathing over 35 breaths per minute. Here, lay back, I'm going to start breathing for you, right? You're going to be like, no, absolutely not. Get that away from me. Even if you did lay down when you're having difficulty breathing and attempted to let them do it, it would be incredibly difficult for you to allow that to happen. So really, the times that we're using a BVM is when somebody is so far gone or they're not breathing at all, their respirations are too slow, or they're unconscious and breathing really, really fast due to trauma or some other issue. So this isn't really going to work on conscious patients. There are some times we might think out of the box and try to do that. The main thing I'm considering here is if somebody's having an anxiety attack and you're trying to help them through slowing down their breaths. One thing you can use a BVM for is a helpful kind of motion. You can put it up to their face, not against it, and have them try to match the breathing rate. That can try to help. But for the most part, they're going to be unresponsive and they're going to really need it. So if somebody is breathing less than 8 times a minute, that's a really good indication to breathe for them. A helpful thing that I like to say is less than 8, ventilate, right? They're not breathing, ventilate them. However, this can be a little misleading because we're not entirely just concerned with the rate. Remember what I said, we're also concerned with the quality. So somebody can absolutely be breathing 15 times a minute and not have appropriate ventilation. That can be due to a shallowness of that breath. It can be due to obstructions or something like that. So we want to consider what we think is adequate ventilation. For the most part, though, if it's less than 8, we're going to ventilate them to begin. We're going to use our eyes to assess whether or not we are giving them appropriate ventilations. So when we squeeze the bag, we're only squeezing enough to see chest rise and fall. There is enough oxygen potential or space potential in that bag that if we're squeezing the whole thing, we could damage the patient's lungs by overexpanding them. So we are only squeezing it enough to see the chest rise. That tells us that we have inflated those lungs. The other things that can really just help tell us is if we see those retractions, especially for people who are in trauma or really fast breathing, that cyanosis, just the SpO2, all of this. You will be able to tell if somebody needs ventilations. If you get there, they're blue, they're laying on the ground, they look sick, they're not breathing very well, you see very shallow chest rise and fall, maybe not even at all, break out that BVM. Now, the first thing that we're going to want to do with the BVM is
Quick
actually,
question.
yeah, go ahead.
If somebody's choked and you're not aware of that, can't you make things worse by doing that? Or
So only if you continued to try to push after you got resistance. So it's going to be so like if somebody is truly like a blocked, if you put this on and you tried to get air in there, it would be just like trying to squeeze like a pressurized thing. So if you were like, oh, it's not, go, right? That's when you're going to force that pressure down further. But if you get there and you can't get anything in there, you're going to be like, it's an obstruction, let's go, right? So yeah, definitely helps with an assessment tool. But if it's that far down, we're not going to be able to tell, even if we did an open of the airway. So it's actually, it would be kind of beneficial to feel that and be like, they have an obstruction, we need ALS, we need to get to the hospital now.
great, thank you.
Yeah, for sure.
Is the supplemental oxygen 100% used with the BVM, or is that discretionary?
So I was just about to touch on that. The first thing that we want to do with the BVM is make sure that we can ventilate our patient. However, as soon as we are able to do that, we are going to attach high flow oxygen, trying to get as close to 100% as possible. So we're not going to waste the time while somebody isn't breathing adequately to set up the tank and attach the BVM. We're just going to get that BVM attached to them, make sure that we can see their chest rise and fall, and then we're going to throw oxygen right on so that we can continue to breathe for them with that higher percentage. So if we're using a BVM, the first step is just make sure it works. It is challenging to bag somebody. And then after we've got that all set, put that oxygen on as soon as possible. Did that answer your question?
Yes, thank you.
Yeah, sure thing. Okay, so some other delivery devices that we have, or at least should consider, are these two right here. So this one down here is just really when somebody has a tracheostomy, they have a condition where they need another airway port, pretty much surgically into their trachea. So it can be a whole bunch of different reasons, throat cancer, anything along those lines that really affects their ability to breathe with their airway. So what this person is actually doing right here is they just have an NRB, a non-rebreather mask, and they have put it over the port of that stoma. That is totally acceptable. There are also masks that are designed for that stoma. So some services carry these. Usually, if somebody in your service area has a condition like this, like a tracheostomy or an LVAD or something like that, they tend to communicate with rescue services. So pretty much the only services that carry stoma masks are the ones who tend to transport people with those. So if you, for some reason, encounter a patient who isn't normally in your service area who has a stoma, you can use an NRB over it. Suctioning is a little bit different when it comes to that, and we'll talk about that on another day. This one up here, we don't really have to be concerned with. This is what we call a Venturi mask. This little pink adapter right here, it's controlling exactly the percentage of oxygen this patient gets. So this is really for people with very specific respiratory issues, and a respiratory therapist or their doctor will say, you need this much oxygen this quickly with this Venturi mask percentage. So there are a bunch of different kinds of these attachments, and it's really just to give a specific percentage of oxygen to this patient. For our purposes, though, if somebody is told to be transported by us, if you ever do like an interfacility transport job, it's really just going to be continue giving them oxygen through their appropriate Venturi mask. We are not able to determine what they need through these. If somebody has a Venturi mask, but they decline, right, we're going to give them high flow oxygen. This is out of our scope of practice, but I'm letting you guys know that you might see this device. It comes out of nursing homes, comes out of other hospitals if we transport people. For the most part, we can just leave it on the patient and respect the orders of the doctor. Oh, CPAP. This one's really cool. This one is an advanced skill in the state of Vermont, but if you guys work on any ambulance that has advanced providers, you might be expected to help set it up or at least recognize what it is. So CPAP, it stands for continuous positive air pressure. So this is essentially kind of similar in sense to a BVM. It is a device that is forcing a percentage of air or creating that pressure to expand those lungs. But this is used for conscious patients, and it's not really forcing them to breathe as it is assisting their ventilations. So it's really kind of cool. I've had one of these on just when we were training to set it up to see what it feels like. You put on this wonky looking mask, can kind of cause some anxiety and claustrophobia in our patients, but you put it on, you attach it to their face, you turn on the device, and essentially it doesn't force any air in until they try to breathe. So as soon as they make the slightest motion, it increases the amount of air that they breathed in, and it tends to expand their lungs more than they could on their own. So it's actually amazing. We put this on people who are in really severe respiratory distress. This is one of those times where a specific respiratory rate needs to be counted in order for you to meet the protocol. So just keep that in mind. But the times I've used it, you put it on the patient's face, they're freaking out, they're breathing really tough. You can tell that they're having a bad day. You put it on their face, they take a deep breath in, and they're immediately kind of like, oh my God, that's so much better. Because you can just imagine trying to breathe through like a really congested or wheezing chest for over 12 hours, and it's really, really difficult. Your muscles get tired. You get tired. A lot of people who die from respiratory distress die from respiratory fatigue. The time of them having difficulty breathing is so long that they just physically run out of energy to be able to take a deep breath. So this device assists them. It just takes all of the weight off of their chest. It just makes them breathe a lot easier. So this device, can't recommend it enough. If you think somebody needs a CPAP, definitely call for ALS so that they can get it. It works really well. The other cool thing is that it has attachments. So if we thought that they needed some positive pressure, but also albuterol, like the medication that comes in an inhaler, we can put it right here so that we actually force that medication deeper down, hopefully actually opening up their lungs a little bit better too. So this has a lot of really good potential for people with difficulty breathing. Definitely call ALS. It's also frequently used for people who have sleep apnea. If it's due to a structural problem or like a weight problem, and they're snoring too much and they actually asphyxiate themselves when they sleep a little bit, you can use a CPAP machine to help breathe. So any questions about CPAP or any of those kind of out of the normal devices? Chris, I remembered what a Venturi mask was called this time.
Great job.
So we actually talked about this a little bit, that mouth to mask. So this is a good way to give somebody ventilations if you have one, and it's kind of the first thing. But for the most part, we want to use that BVM because of the increased ability to give them oxygen. These are essentially just the masks that we do use on BVMs, but they have a couple filters in them so that it kind of negates the grossness of doing like mouth to mouth ventilations on somebody that you just met. Especially in the age of COVID, even through like teaching CPR classes, we've pretty much said, unless you know this person really, really well, don't give them mouth to mouth. Just do compressions. That's what's going to help. So that kind of goes the same thing for EMS. Is like if you don't have a BVM, but you have a mouth to mask, do it, but hope that a BVM gets here sooner because that's really what's going to be effective. Again, back to that stoma or the tracheostomy tube, it usually is pretty universally acceptable for like devices like a BVM. You can attach it right to that stoma without the mask, and you can give somebody ventilations that way as well. That's just another good picture for you. Now, this is the last slide of this presentation, I believe. One consideration, especially when we're managing the airway in the older population, is dentures. We don't want to make them become an obstruction of the airway. We don't want to hurt the patient or anything like that. So if we're going to need to be in that patient's airway and they have dentures, if at all possible, just leave them in place. Usually dentures are pretty good about staying in place, right? They have an attachment way to keep them there. But if they're loose, don't worry about trying to put them back. Just remove them both. If they are working fine, leave them there. If they're not, just get rid of them. And just reassess frequently, even if they are in there, just to make sure that they haven't become an obstruction. Any questions about the airway management slides? Again,
if
final thing
there
here,
are-
airway is the first thing we're really doing all the time. It is a very important facet of our assessments. If we can find an airway issue, we can save that person's life. And we have a whole bunch of different tools that we can use to make that happen, from suction to just maneuvers, that head tilt chin lift, that jaw thrust, to our OPAs and MPAs, and then finally to our oxygen, specifically with our BVM. That can make the difference between somebody asphyxiating and dying versus you breathing for them and saving their life.
All right, I think this would be a good time to take a break. Why don't we all come back at 7:10?
I can't hear you, Chris.
Oh, well, that's a problem. Can you hear me now? Okay,
The rest of us can hear you.
okay. So let's take a break and come back at 7:10.
Can anyone else hear Chris?
I can hear Chris.
Yeah, she
Yes.
said to take
Maybe
a
I just
break.
can't hear you guys.
Yeah, I heard her.
Yeah, she said take a break and come back at 7:10.
Yeah, I can't hear anybody.
It's you.
It's me. I'm the issue here. Of course.
All right,
Here,
we'll
Chris,
see you
you take
guys
over.
back
I'll
at
come back in.
7:10. All right. So we're going to switch topics a little bit. Well, before I get started, does anybody have questions for Kevin? All right. Okay. So we're going to switch gears a little bit, and we're going to actually now talk about some medical legal stuff. In the class on Saturday, some of these started to come around. And so we're going to kind of review things about consent and all sorts of medical legal issues tonight. So let me ask you a question. The answer is kind of obvious, but do EMS providers get sued? Yeah, we absolutely do. And before I get started, on Saturday, I had sent you 2 links to 2 articles. And I'm wondering, did folks have a chance to read them, and what were people's thoughts about them? So let's maybe talk about the case with the baby that was born in the toilet. What did folks think about that?
I was actually talking to my director here in Fairfax about it, and I was like telling her about the article and everything, and she was actually saying that they had an EMT a couple years ago that had a baby that was to resuscitate the baby, and they're still getting updates on the baby 2 years later. So she thought it was absolutely insane that those providers didn't pay any attention to that baby.
Yeah. Yep. I would agree.
Also, can an EMT cut the cord?
Yes, an EMT can cut a cord. That is absolutely okay. As long, there's some things that you have to be mindful of when you do it, but it is in your scope that you can cut a cord. Any other thoughts about this case, right? So they determined that they didn't do resuscitative efforts on this baby, right? So they wrapped the baby up. They determined it was born premature. They wrapped the baby up. They took the baby to the hospital with them. And then when they got there, the emergency department started resuscitative efforts.
Well, didn't they also leave the baby in the toilet and bring the mom into the other room while the baby was in the water as
Yes,
well?
they
So
did.
there's obviously some significant neglect, and obviously there's a malpractice style to all of that as well, based on the fact that they would just leave the baby in the toilet.
And they also put it in a hazardous waste bag too.
Yeah.
Mm-hmm. Mm-hmm. There's actually another case out of Massachusetts. Now, you would think that this might just be a one-time thing, but there's actually a case out of Massachusetts similar, where the EMS providers said that it was also a premature baby born early, and they determined that the baby was deceased, and so they put it in a box and brought it to the emergency department with them. And when they got to the emergency department, the baby actually still had a pulse. So they had provided no care, and then the ED took over, but the baby subsequently died. And that family sued as well, and they won over $1 million. Yeah, Jason, you were going to say something.
Say EMTs can't determine death, though, right? The role is to continue treatment, but we can't pronounce whether somebody is alive or dead or not, correct?
So in certain circumstances, we can. So it's within an EMT scope of practice in certain circumstances to say this patient is deceased, and we are not going to start resuscitative efforts. And those are very specific. They are that the patient is in rigor mortis, that the patient is showing signs of lividity, which is this pooling of blood. It pools to the lowest part of the body from gravity. Incineration, decapitation, which would also include not what you typically think of when you think decapitation, but it also could include like a gunshot wound to the head where part of the head and part of the brain was showing. And then decomposition. And those are all like, those are 5 very clear cases. Those are 5 very clear cases where no resuscitative efforts are going to work. So in those instances, an EMT has the ability to say, this patient is deceased. We are not going to start resuscitative efforts, though we would have to document, we didn't start resuscitative efforts, and this is the reason why. So you do. I will also mention that blunt and penetrating trauma can come into play. The protocols are, and Kevin, you want to look it up while I'm thinking about it? Because it just changed. It used to be if our patient showed signs and symptoms of had experienced blunt or penetrating trauma. So blunt, think a significant car crash, a lot of blunt force trauma. You get there and your patient's deceased. And then penetrating trauma would be things like knife, gunshot, things like that. So penetrating type wounds. One of them you can declare immediately, and one Kevin, you're looking it up. Thank you.
I have a question. So if you come on scene and there is a mother and baby and both of the patients are in distress, what is the protocol for who you treat first?
You treat who's the more significant in distress. So you would have to triage your patients and decide who's more serious, or you could, if you have multiple people, split your resources and then call for another ambulance. That's a really good question.
Chris, I have another question about, like building off the deceased question.
Yeah.
When is it in the protocol, and I'm sure we'll get to this, appropriate to stop care once you've started? Like if you've started CPR on a patient, other than the scene becoming unsafe, are there times when you say we're not doing this anymore?
Yes. So we'll talk about that when we talk about cardiac arrest management. But it is in an EMT's scope of practice that when certain conditions exist related to the patient, that after 20 minutes of resuscitative effort, whether at a BLS level, which is EMT, or at a combination of BLS, ALS level, after 20 minutes, if you haven't been able to get a pulse back, where you can call, you have to call and get medical directions permission to terminate resuscitative efforts. So you would call and you would say, hey, it's me. We're on scene. This is what's happening. I'm requesting permission to terminate resuscitative efforts. And in most instances, the doctors will give you permission to terminate resuscitative efforts. Sometimes they don't, even though your patient might meet the protocol, sometimes they don't. And usually if they don't, it's related to the age of your patient. So, and when you think about it, think about how you would feel, right? If I said to you, you're terminating resuscitative efforts on an 80-year-old, a lot of you might say, well, they're 80, they've had, hopefully they've had a good life, they've lived 80 years. You can rationalize that versus if I told you you were terminating resuscitative efforts on an 18-year-old. Does that honestly, think about that. Would that make you feel differently? And so doctors sometimes will say, even though you meet the criteria to terminate, they'll say, hey, keep going and get them up here. So did you find it, Kev?
Yeah, so I don't think the update is in the 2020 version. Didn't they release something else? Because this one just still says any blunt or penetrating trauma.
Okay, so it is currently still any blunt or penetrating trauma that you can terminate, that you don't have to start resuscitative efforts. Thanks, Kev. I wasn't sure, but in the 2022 protocols, which I'm told will come out at some point while you're still in class, those 2022 protocols will have an update, and that will change where they take the thought around trauma is your chances of resuscitating a patient who's in cardiac arrest related to trauma are a lot less than your chances of resuscitating a patient who's in cardiac arrest from a medical reason. And so right now we could terminate, but that's going to change, and it'll be related to what the trauma is and how long it's been since the patient's been in arrest. So I know that that's what it's going to be related to. So thanks, Kev, for looking that up.
For sure.
All right. But I think you can see a lot of things, right? So it is in our protocol to terminate or to make decisions about resuscitative efforts. Did this case with this premature infant meet that circumstance?
No.
No, it absolutely didn't. What did you all think of the second case where there was a 31-year-old who shot himself in the head, but still had a pulse and was breathing on his own? Protocols anywhere would call for you to transport that patient as quickly as possible. But there was a determination from someone that said that they decided that the patient was unsalvageable, and they ordered first responders to wait for the man to die.
Took
And
5 hours, right? It took like 5 hours.
They stayed with him for 5 hours, where at times where he was in pain and moaning loudly. And after 5 hours, they got permission to administer the patient ketamine. And then they covered them with a sheet and transported them to the hospital. And ultimately, the patient died 10 hours after the 911 call was made.
So I have a question about that.
Sure.
So I know I've been on calls, and we get a call from dispatch about every 15 minutes to check on our status. Why would this fall into the category where dispatch would also be responsible for not sending somebody else out there to see what was going on?
No, not if she was checking on their status and they said that they were all set.
Okay.
Though, to be fair, there are multiple lawsuits out there against 911 operators for the 911 calls that they take, whether they didn't send an ambulance when an ambulance was needed, or I just read a case. I was working on a different project related to medical lawsuits in EMS. And so I was looking up all sorts of cases. And there's another one where the 911 call taker started having words back and forth with a 911 caller who said that their loved one was in cardiac arrest. And she hung up the phone and ended up just dispatching the EMS to a patient with chest pain. And so that call didn't get the same resources that it would have gotten if they had known that it was an actual cardiac arrest call. So, yeah. So what did we think about? So, and you got to remember, EMS is different in different places in the country, right? For in most states, the EMT course you're taking now is the exact same that they get. We all follow the same. This is what we're going to teach. But outside of that, within their state, there can be some things that were different. In this call, what was different was the person that told them not to transport the patient was their medical director, who was a doctor. And so he's the one that determined this patient is unsalvageable. Don't transport him, just let him die at home. And he was the one that after 5 hours, when the patient hasn't died and was showing signs that, expressing that they were in pain, said, give them ketamine. So do you think that gets the EMS providers off the hook? What do you think? If they're getting sued, they've had action taken against their license. Their licenses have been suspended.
Wait, do you mean off the hook morally or off the hook legally?
Off the hook legally. Morally, they're not, no doubt.
I think they could have fought for their patient, because I know personally, if I was standing there watching a patient suffer for 5 hours, after 15 minutes, I probably would have been like, all right, this is ridiculous. We need to give them some medication, whether we're transporting them or not.
Right.
Yeah, like, is there room to defy an order from a director like that?
Well, it's a doctor. What do you think?
Because when we call our medical direction and we ask for advice, essentially patient care, I guess, gets transferred to legally patient care gets transferred to that, and it's on their hands, essentially, is what I've been told.
So let me ask you a question. You, an EMT, you've gone to a patient and they require a medication. And in your scope of practice, you are only able to give them 5 milligrams. When you call the doctor, that doctor who is now putting their license on the line says, give them 10. Can you do it?
I believe so, because
Absolutely not.
Okay.
So this is where this case comes in with this case where the EMS providers, they listen to what the doctor said, who said, nope, this patient's not salvageable, don't transport them. But that patient was alive. They had a gunshot wound to their head, but they were alive. They were breathing. Their scope of practice, their standard of care, 2 different things, but both come into play. The standard of care for any EMS provider, doesn't matter the level, paramedic, advanced, EMT, doesn't matter. Your standard of care is if you have a patient who's alive and breathing, who needs medical care, what are you supposed to do with them? Get them to the hospital. And so they didn't do that. They violated what they were supposed to be doing. Even if a doctor tells you, does not mean that you can do it. And that's a good way to go into the lecture. So I thought I would send them out for some thought provoking. You guys had some good discussion. Can EMTs get liability insurance? I don't know if you could probably get some individual insurance of your own. Your department will have a liability insurance as well. So we do get sued because we do make mistakes. I will tell you that the majority of mistakes that we make where we really get in trouble, the biggest areas we get sued are related to accidents. And then the next biggest mistakes that we make are usually related to the medications that we give. Though I'm not going to lie. I've seen some EMS providers make some pretty poor decisions.
If you didn't have personal liability insurance and the department did, it seems like somebody would sue the department since they have deeper pockets.
Oh, they absolutely will. They absolutely will. They're going to go where they can get the money. They absolutely are.
In Vermont, do they have to make a decision on filing only a single suit, or could they just sue everybody involved?
I'm not positive, but I would imagine they could probably sue everybody involved if they wanted. The good news is I don't know of any lawsuit cases here in Vermont. But like I said, I was asked to do this project earlier this afternoon, and this pile here is all cases of EMS providers being sued for things that they did, including some things that I've seen actually done here in Vermont. Okay.
What would the liability be if they did transport that patient and they were found to be unsalvageable at that point and they refused to follow doctor's orders? Would there be repercussions in the other direction at that point?
So that's also a really good question. And the answer is no, they wouldn't have, because what happens is as long as they followed their standard of care, they were fine. So it's not like the doctor can come back to them and say, oh, you didn't follow my order, I'm going to pull your license. The doctor can't do that because the doctor was the one that was really wrong. The doctor never should have told them not to transport that patient. And that doctor is in legal trouble as well. They're all in trouble. But for the take home for all of you is you need to know what you can do and what you can't do. And if a doctor tells you to do something that you know that you can't, You should not do it. You absolutely should not do it.
What's the right way to resolve that with the doctor?
Yeah, most doctors are really good. And if you go back and say to them, oh, hey, Dr. Adams, that isn't in my scope of practice. I can't do that. The doctor will usually say, oh, okay, no problem. In all of my career, I've only once seen a doctor insist that an EMS provider do something that they couldn't. And what it was they told an EMS provider to take a patient to the hospital against their will. The patient was alert, the patient was fully oriented, and they made a decision. They told the EMS providers, I don't want to go. I understand I might die. I would rather die at home. I don't want to go. And the doctor told the EMS providers to kidnap. That was her word. Kidnap the patient if you have to get them there. So the EMS providers did what they thought was the right thing, and they called law enforcement. Law enforcement came to the scene because they knew they couldn't just do it. And law enforcement did their due diligence, and they contacted, I don't know if they contacted the state's attorney or they must have contacted somebody they contacted who said, no, absolutely not. They cannot take that patient. So EMS said, we cannot take this patient, called the doctor back and said, there's no way we can take this patient. Law enforcement isn't going to help. It can't help us because there's no right to take this patient. And the doctor tried to pull licenses and lost. So the doctor wanted to pull licenses, and the decision was made that the doctor was wrong. So I've only seen that happen once.
What happens when it's something not with the doctor at the hospital, but within like your specific EMS staff?
What do you mean?
And the person who's higher ranking on that shift is like refusing to transport a patient, et cetera, but you think that they need to be transported.
So at the end of the day, if the patient wants to be transported, you transport the patient.
I guess I just meant like in general with this whole, like everything we're talking about. Kind of like with the medical director at the hospital. Like what if that happens within your EMS staff on that call that night?
So the crew can have a discussion about what they can and cannot do. Ultimately, they have to follow what their scope of practice is. If you had a disagreement on scene about whether a patient needed to go or not go, the first thing I would want to know is, what does the patient want? Okay, because at the end of the day, it's up to the patient. It's not EMS providers. If we have a patient that wants to go to the hospital, we have to take them to the hospital. Even if we don't think that they need to go, even if we didn't think they needed to go, if they want to go, we take them. And we've seen this happen a couple times recently where patients want to go and EMS providers have said, no, I don't think that you need to go. No EMS, the only way you could really do that was if your patient had a care plan, and care plans are drawn up for patients who abuse the 911 system or are regularly, they're calling 911 all the time to go to the hospital. Medical directors can put care plans in place that spell out when the patient can come. So we have to be really, really careful with that.
Ashley, I'd say that if someone on your crew is telling you to do something that is not legal or
don't do it,
not within your scope of practice, don't do it, and contact your supervisor and their supervisor to have a discussion with them about what's going on.
Right. And try not to argue it out in front of the patient.
Yeah.
I actually have a question. It's about DNRs actually. I was wondering.
I'm going to talk about those, but go ahead.
Okay. No, my question was, say there is a patient that does have a legal DNR in play, but they are injured and still ask for transport. Like, say they go into cardiac arrest, but they still want transport. What would we do there?
So you asked like two different questions. So the first answer is if they have a DNR and something happens where they're sick or injured and need to go to the hospital, we take them to the hospital. DNR is very, very specific, and it so only means that should the patient go into cardiac arrest, we do not start resuscitative efforts. But if their heart is beating and they're having difficulty breathing and we get called, we help them with their difficulty breathing. We would do what's in our scope of practice to do. What you asked second was, I think, was what if they change their mind? Is that what you were asking?
Yep.
So if we got to their house and they were really sick and we knew that they had a DNR and they said to us, I don't want to die, please do everything, then we would do what the patient asked us to do.
Okay.
Okay,
because that
so if
would
they said that,
be-
right, so if they said that to us and then they went into cardiac arrest, if we could document patient expressed they did not wish to die and asked us to do everything, then, and if we did everything, we would be okay. I will also say that you have to hear that from the patient though. So if a patient has a DNR order and you get called and you got called because the family changed their mind or the family didn't agree or the family was just right, that's a lot of emotion, and they panic and they call 911 and they tell you, yep, there's a DNR, but I want you to do everything. You're supposed to respect the paperwork.
And if the patient makes a request, how do you determine if they're mentally competent to make that statement?
Are they alert and oriented? All right. So these are all really, really good questions. So let's just talk a little bit about medical direction. I mean, about medical legal. And I wanted to start with medical direction, right? So the medical direction, that is the physician responsible for our clinical and patient care, right? So it's the doctor at the hospital. And we have, medical direction plays a huge role in emergency medical services. If you're with an EMS service, your service has a medical director. This EMT class that you're taking, this EMT class has a medical director. And they play a big role in what we do. Every district, so Vermont is divided into EMS districts, so, and they're related to the hospitals that they transport to. Every district has a medical advisor. And these are the folks that we call when we need assistance. So for some of the questions that you're asking now, they're our lifeline. So there are two types of medical direction that you need to be aware of. One is offline. And offline medical direction are those things that are either in your protocol or directions from your local medical director that they've given you ahead of time. You can do this. So I don't need to call a doctor to give a patient oxygen. I don't need to call a doctor if I have my chest pain patient who I want to give aspirin to. So that's offline. It's within my protocol to do that. And medical directors play a significant role in our EMS protocols. So when the 2020 protocols were in, the new ones are going to be coming out. All the medical directors from around the state have input into those protocols. They play a big role in that. And our protocols themselves, the primary writer of them is the state medical director. State medical director for Vermont is Dr. Dan Wilson. And he's the one that writes them. And then all the other medical directors have input into them. The second type of medical direction is online. And that's when we talk to a doctor, when we have to talk to a doctor. So through the course of the class, we'll talk about some instances where you might actually have to call and talk to a doctor to get permission before you can do something. And those are spelled out in the protocol. If you look in the EMS protocols, you'll see in different places where you'll see little telephones. Those telephones are your visual cue that requires a phone call to medical direction. The other thing that medical direction is really good for is when we come up against those calls that we're struggling with. The patient that we think needs to go to the hospital that doesn't want to go. That requires a phone call to medical direction and having a discussion with them. There are certain instances where we might be making a decision to not transport our patient. Some of those require phone calls to medical direction. And there's certainly a lifeline for us when we're not sure about something. So hopefully by the end of the class, we will have one of the medical directors come into class, and they like to come in and do a presentation about what they're looking for from you when you call. So we'll work on getting that set up. Okay, so we already know EMTs can get in trouble. So the best way for EMS providers to stay out of trouble is to follow their scope of practice. So your scope of practice is the law that defines what it is that you can do at your particular level. Whether you're an EMR, whether you're an EMT, an advanced EMT, or a paramedic, that your protocols spell out what you can do for all sorts of different medical emergencies, trauma emergencies. Yep, Kevin's got a picture up on the screen. That's exactly what they look like on the inside. And it spells out what we can do, what's in our scope of practice. And it's important that you know that. It's important, it's vital that you know your protocols. And if you don't, before you make a decision about what you're going to do with a patient, just refer to your protocols. I do it, EMS providers do it all the time. It's impossible to memorize everything in that book. So if I'm not sure, I have an app on my phone. If I'm on a call, I just go into the app, I look it up. That's my medication dose. Oh, yeah, I have to do this. Oh, wait, I got to call medical direction first. Our protocols spell everything out very, very well. And this is really important that what we know, what we can do, and that we stay within that scope. The next term is standard of care. And really, that is that as an EMS provider, you're expected to provide the same level of care that anyone else with the same training would do. And standard of care really comes into play if you end up in court, right? So if you end up in court or a question comes up about something that's done, they will go and say, well, what would any other EMT do, right? So going back to the case with the 31-year-old who had a gunshot wound to his head. The standard of care says at any level that if you have a person with a gunshot wound to their head and they are breathing and they have a pulse, you should transport them to the hospital. In no place, in no scope of practice would it be within any provider's scope to say, yeah, but I don't really think this person's going to survive, so let's just hang out here until he dies. That's not in any provider's scope to do that. So making sure that you know this is really, really key. And it'll play out as we talk about. So when EMS providers get sued, they are sued for negligence, right? So we're sued for negligence. And so really what has to be proven is that we as an EMS provider did something, we deviated from our standard of care. And because we did that, the patient was injured. Or we could look at it that we didn't provide the same care that a person with similar training would do, right? So I look at it this way: to prove negligence in EMS, to prove negligence, there are 4 things that must exist. The first is we have a duty to act. So when does an EMS provider's duty to act start?
When a call comes in.
Start immediately.
Yeah, it starts when we get when the call comes in. So we have a duty to act. When we get a call and we hear where, this is where we're going and this is what it is, we have a duty to respond to that call. We do not have an option to say, oh, wow, oof, it's a GI bleed. Ugh, I don't really want to go to that. I think let's just have them send the ambulance in the next town, right? We can't do that. We get the call, we have to go. So that's our duty to act. The second part of proving negligence is that we breach our duty. So we either did something we weren't supposed to do, or we didn't do something that we should have. It's usually one of those 2 things. We did something we shouldn't have, or we didn't do something that we should have. One or the other is usually where it plays out. The third one is proximate cause. So what role did our deviation from the standard of care play in injuring? The third one is that the patient suffers because of that. So they sustain some sort of harm. And then the fourth part is proximate cause. How much of what we did played into the patient's injury or outcome? So I'm going to give you a couple of examples. You are on duty, and it's right now, it's tonight. I don't know if it's pouring where you are, but it's pouring where I am. And we get called out to the interstate for a motor vehicle crash, vehicle down in the median. We get down there, the patient's in the car, they've got some back pain and they have some leg pain. So we extricate them out and we put them onto a backboard. And we ask that great question: sir, on a scale of 1 to 10, could you please rate your back pain? And they say, it's like a 3 or 4. So then we get the patient all packaged up. We start to go up because it's down into the medium. So you got to go up to get to the road. All of you were in lab the other day, saw how tall I am versus how tall Kevin is, right? So Kevin and I we're on equal. He's on one side, I'm on the other side of the backboard. And we are moving that patient up the hill. Kevin's a lot taller than I am. So I'm trying to struggle with the backboard because our heights are off. And I lose it. I start to slip. It's raining out, by the way, right? It's pouring, it's muddy. I slip and down goes the patient. Down I go. I bring the backboard with me and boom, we drop the patient. We very quickly are embarrassed, pick up the patient, take them to the ambulance. And we put the patient in the ambulance and now they're hollering in pain. Oh my God, my back is killing me. Did we have a duty to act? Yes. Did we breach that duty? It's raining, it's slippery, it's muddy. We dropped the patient. Did we breach our duty?
I would say no, because you had the elements against you, but you could have called for maybe a lift assist or something else.
Right. I would say we breached our duty. It's bad form to drop your patient. And if we don't think that we can move them safely, we have to find a way to move them safely. Go ahead.
I don't know if it's maybe like neglect. I just want to know if it's breach of duty, something like that. So a lot of us are probably going to be responding from home to the station or home to someone's house.
Mhm.
So they were responding to the station, it's a snowstorm, and for some reason our car goes off the road, but dispatch knows we're going to the station. We call them to dispatch saying we had an accident. Would that be considered neglect or anything like that?
No,
Okay.
nope, wouldn't be.
What if the patient was in significant distress and calling for additional support would take too much time? How would you get them out of the median strip?
I'd call I'd call the resources I need to do it, and to do it as quickly and as efficiently as I can, but I have to do it because I don't want to injure them. So I don't want to do it so quickly that I get hurt. Do EMS providers drop patients? Yeah, Kevin and I, between Kevin and I bet we know a couple people that have dropped patients, right? Now the third part, proximate cause. What role did us dropping that patient play in their injury? Is it all of their back issue?
No.
What do you think? I mean, they had back pain before I got out of the car, before we started moving them. They had some back pain, but they did suffer harm. Am I going to win that lawsuit? Can they sue me?
Yeah.
Yeah, they absolutely can. They absolutely can.
It's a very subjective thing though, right? At that point. And so
It is. And that one's it is, but a lot of people would sue for that. Right? A lot of people would sue for that because they got dropped. At the end of the day, they're going to call in experts. Here, I'm going to give you another one. Tomorrow morning, you're on duty and your pager goes off for a cardiac arrest call. And you get there on scene, you get there really quick, you go in, you apply your AED pads, someone's doing CPR, you turn the machine on, you're ready to analyze, and the machine goes beep, beep. It says, check battery, and it shuts off. Battery was dead. So you don't panic. You go into the pocket of the AED and where you keep the spare battery, because we always have two, and you just flip them around. You put in the spare battery, turn it on, turn it on, machine beeps, shuts off. You're still trying not to panic. So you have your crew continue with their phenomenal CPR. And you, very quietly, try not to make a big scene about it. You call for additional assistance. You need a defibrillator brought to the scene. Somebody comes with a defibrillator. You attach it. You attach it. You get some no shocks advised, and you end up terminating resuscitative efforts because the patient met the TOR rule, or even better, you transport the patient. You transport them to the hospital even, but ultimately the patient dies. The family, they watch a lot of TV. They watch a lot of TV. On TV, what happens a lot of the times when a patient goes into cardiac arrest and EMS shows up and they do CPR and they apply a defibrillator, what normally happens?
They live.
They live, right? So the patient realizes that their family member didn't live, and they realize that there was some sort of a problem, even though it appears you handled it well, and they sue you. And you end up in court. Did you have a duty to act?
Yes.
Did you breach that duty?
No, because you tried all your best efforts and you called for someone else to come in with a piece of equipment. And it was failure of the equipment, not failure of yourself.
Anybody
Oh,
want to
could it be-
It was, but
But
it was
did
your
you check
failure.
it before you got there?
I would disagree with that.
Isn't it your responsibility to make sure that you have working equipment?
Yeah.
Right. So there you go. Did the patient suffer harm?
Sure did.
You can't prove that it was because of that machine, could you?
Did the patient suffer harm? They died, right? what was the proximate cause would be what it would come down to, right? You'd have a lot of experts in court trying to decide. They'd be calling in the best of experts to say what would that patient's chance of surviving had been had the AED worked immediately when you got on scene, right?
So you're
That's
saying
what
it-
it'll come down to.
It comes down to like rolling the dice whether they died of a stroke or cardiac arrest.
There'll be an autopsy. They'll call in all sorts of legal experts. But what it comes down to is, did we breach our duty? Was it our fault?
Right, yes, because we didn't give them life-saving care that they deserved in those moments, right?
We
Due
did
to
the
our
best we
negligence.
could.
Well,
Great
due to our
CPR.
negligence. we
How
did
many
not.
of you were on services? Nate, you're on a service,
Yeah.
right?
Yes.
Okay. You do rig check?
Yeah, we do rig check regularly. We have our
How
results.
often?
We do it. We do maintenance nights once a month, but on the way back from our calls, I check inventory because it's a long commute. I check that the Zoll works. I check.
Right, but how, right, so some services, and this is what it's gonna come down to.
Yeah.
What it will come down to, Nate, will be, when was the last time anybody put fresh batteries in the machine?
Yeah, we do ours. Every maintenance night we check them. So once a month we check them.
Okay.
But we're
So-
always like, we always cycle out the batteries.
Right, so some services do it,
Airchecks does their rig checks at each shift change.
right, and how often do you rotate the batteries? Do you know?
We have,
I think the batteries are every couple of weeks. I could be wrong though. We have a sheet down at the station. They have to be switched.
Right.
every
This,
so
what we're
often.
talking about right here is what it will come down to. And and this is a great example of where the standard of care will come in, right? There's no protocol written that says how often you should be doing rechecks or how often you should be checking your batteries and rotating them, right? There's no protocol written about that. But what's the normal standard of care? And granted, that standard of care may look different in different places. But that's what it'll come down to. And it'll
What is
come
the-
down to, what was your department's policy? Had you been following it? And do you have it documented that you switched those batteries out, right? Like on my service, we do rig check once a day. Those batteries are tested every single day. And all of that is documented in a book. That book's going to end up in court if that happens. So
Who does the liability reside with in a case like that?
it'll reside with the service. Yeah. So this is the part, this part right here, the deviation, right? Doing something you shouldn't have or not doing something that you should have. I have seen EMS providers make bad decisions and not do things that were in their scope of practice. I've sat with a couple of different EMS providers just this year alone who made some really bad choices about not following their scope of practice, not doing what they were supposed to do. And in some instances, their patients suffered harm because of it. So make sure you stick to what you know and what you're supposed to be doing. All right. The third term I want to talk about is abandonment, right? And so it is what it sounds like. You abandoned your patient. And there's a couple of ways that an EMS provider, can be found to have abandoned their patient. One would be that what we were talking about earlier about saying, you know what? I don't think you need to go. You're all set. With when you have a patient with saying, no, I don't feel good. I want to go to the hospital. And you just saying, no, you don't need us. You're fine. That is a form of abandoning your patient, right? So you're stopping care without their consent. So that's a problem. If they want to go, you've got to take them. The second one would be termination of care without provisions for continued care. Any folks on here first? I know a couple of you are first responders because we talked the other day in class. So you're a first responder. It's 7:30 in the morning, your pager goes off, call is literally 2 doors down from your house. Chest pain. You get in your car, whoop, down the 2 doors you go in with your equipment, you start taking care of the patient. Your primary ambulance is already out on another call. So you have to wait for another ambulance to come. And that's going to take longer. And you look at your watch and you realize you're going to be late for work. And you know what? Your boss has already warned you because you've missed so much work because you've been going on all these EMS calls. If you're late one more time, you're going to be fired. So you radio dispatch, who's coming, you radio the ambulance, how long before you're going to get here? Oh, you're going to be here in 6 minutes? Great. Mr. Upton, keep this oxygen mask on your face. Just keep breathing. You'll be fine. The ambulance will be here in 6 minutes. Have a good day. And you walk out the door. That would be called abandoning your patient. So you can't do that. Another example of this would be, an example that I've seen recently is you're on a call and you're taking care of your patient. It's a lift assist. You just got to lift them up, get them back into bed, and then they're going to sign the non-transport form. But before you can do that, you get another call. Your pager goes off, beep, 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 and this call sounds serious. So you say, oh, hey, Mr. Smith, hang tight here on the floor. We're going to go take this call. We'll send somebody else here back. We'll send somebody else to come and pick you up and do that non-transport form. Have a good day. And you leave that patient to go take another patient. That is abandoning your patient. And then the last one would be that once you at a certain level start providing that care, that level of care to a patient, that level of care has to be continued. So either you can hand off a patient to someone of equal or higher certification, but not lower certification. So I'm a first responder. I jump a call. I'm an advanced EMT. So you guys pop up on scene and you're an EMT crew. I've started an IV. I've given meds and I am running fluid. And I say, yeah, I can't go to the hospital with you. You should be all, Samantha, you look like you know what you're doing. Here you go. Take the patient. You should be fine. And I turn the patient over to someone of lesser training and expect them to monitor my care. So that is also abandoning your patient. So we have to be mindful of that and be careful that we don't do that, because that will get us in trouble too. There are multiple lawsuits for EMS providers. And usually when it comes to abandonment, it's around terminating care without the patient's consent, where they've made decisions like that.
I have a question
Yeah.
about signing off to someone equal or higher training. So what do you do in the case if there is a certified nurse who is also an EMTB? If they have the training, like IV fluids and medications on all that, like I feel like that is kind of a gray area for me. If you could give
So a nurse, I'm having a little, you're very quiet to me, but did I understand a nurse who's certified as an EMT?
an EMTB.
Yep.
They go to a call where so what does that do? Like your certifications, what takes priority?
So if she's running as an EMT, she can only operate it. He or she, I shouldn't assume. He or she, they can only operate at the EMT level.
Okay.
Right. So if nurses want to become EMS providers, they don't necessarily have to take the class. They can challenge the exam. So nurses and PAs, physician's assistants, can challenge the exams, but when they're on the ambulance, they can only operate within the level that they are certified at.
Okay.
So a nurse cannot provide nurse care when when they are operating as an EMT.
Okay. Thank you.
Yep, that's a really good question.
Chris, I have two questions.
Yeah.
Let's say you first respond as a AEMT,
Mhm.
but your transport ambulance is a BLS crew.
Yep.
And you're only providing BLS care.
Excellent question, Andrew. I can hand the patient over.
Got it. So it's all based on the level of care you're providing, not
Yep.
the certification.
Yeah. So if I haven't started any of my advanced care and the patient doesn't need it, I should also preface it with that the patient doesn't need it. Then I'm fine to hand over to a BLS crew. Another challenge would be, and we've seen this a couple times, where the people of lesser certification levels are in the back of the rig providing care, and the highest level person is driving the ambulance. So that can be challenging depending what's going on with your patient. Andrew, you had a second question. Sorry.
Yeah, the second one, let's say your agency is dispatched to 2 calls either simultaneously or very close together. Let's say one is a lift assist and one is a seizure. And you're already en route to the lift assist and you request dispatch to redirect the second ambulance to the lift assist because you're going to take the seizure.
Mm-hmm.
Would that be abandonment?
Believe it or not, that's a really gray area, because the argument could be made, well, you haven't started care, so you should triage the calls and take the more serious one. And certainly if they came in simultaneously, you could potentially do that. I will tell you that there's a case to be made, however, that calls aren't always what you're dispatched to, as anybody that's running calls knows that. And so you should continue to the call that you're dispatched to and have the next ambulance take the second call.
Yeah. I was going to say, out of those 2 dispatches, seizure and lift assist, I would say that those are the 2 most misleading dispatches. I have been to so many lift assists that turned out to be cardiac arrests or something much worse.
Yep.
I've been to plenty of seizure calls that have turned out to be somebody who just fainted or stubbed their toe.
Right.
So
this actually came up at least locally here in our area, Andrew. It came up a couple of years ago, and the guidance from medical direction was you take the call you're dispatched to and you send the second ambulance to the second call.
Do you feel it makes sense to me? And obviously you can what if this particular scenario to death.
Yes.
Do you think there'd be a case, let's say the second call was a cardiac arrest, and again, the first one, something more routine that doesn't elevate your stress levels, and you stick with the routine call and the second one ends up expiring? And do you think there's any case for legal action against your crew at that point?
I suppose somebody could try it, though probably what's going to come back to is they were already committed to another call.
Yep. Okay.
Is what it would come down to. And that really, you're talking legal versus like what you feel morally compelled to do, right? You morally feel compelled that you should go to the more serious of the calls. And this is a tough one for EMS providers. And if you've been on a call, like I've been in cases where I'm like, oh my gosh, right? Like we really should be going to that call, but we were committed to the call we were committed to. So you have to be careful.
I mean, even if like you get paged like simultaneously and the second call comes out to be more like comprehensive, you can always page for ALS, and like, Milton's paramedic could come to Fairfax too.
Right. No, it's a really good point. And it depends on like EMS is particularly in Vermont is very different depending where you are. Right. So it's easy for me to say, well, just send the second ambulance, because here where I run, second ambulances are usually readily available. But I know I was talking to a couple of you on Saturday where your first ambulance might be 30 minutes away and that second one's going to be 45. And so sometimes you may want to split your crews and do other things. You could split your crews and have first responders go to the other call. Yeah, it can be challenging. It absolutely can be challenging. All right. So consent. So we have to have consent on every single patient that we transport to the hospital. And consent is that patient gives us they're okay to take care of them. So express consent is the easiest. Hey, can I help you? Yep, you can. I called you. This is what's going on. And they give us permission to start taking care of them. Implied consent comes in for a patient to give consent. They have to be conscious, they have to be alert, and they have to be fully oriented. And they cannot be under the influence of alcohol or drugs. And by that, I mean significantly impaired by alcohol or drugs. They have to be significantly impaired by them. Not just that I had a drink of wine and then got into a fender bender on my way home. Maybe I legitimately only had one glass of wine and I actually am fully alert and oriented. So implied consent comes into play with when a patient is unable to give express consent. Their altered mental status, they're unconscious. Implied consent just says that the patient would want us, if they were fully alert and oriented, they would want and knew what was going on, they would want us to take care of them. So that's implied consent. For minors, we have to have permission from a parent or a guardian. So, and that's anyone under the age of 18. So the 17-year-old that crashes the car, that tells you, I don't want to go, we have to talk to a parent or a guardian. For minors that are severely injured or really sick, where we would consider them that high priority patient that we've been talking about, implied consent comes into play. So little kid rides their bike out of mom and dad's sight for the first time, down the street, around the corner, and they get hit by a car. We're not going to take the time to call mom or dad or parent or guardian to say, hey, by the way, your kid just got hit by a car. Are you okay if we take them to the hospital? Right? If they're seriously injured, we're going to take them because implied consent comes into play. If the parents knew, the law assumes they would want us to take care of their child.
If the child's conscious, do you have a requirement to attempt to contact the parents or anything?
I would want to contact them, but it would depend on what's going on with the kid. So if I had a kid, that's conscious, you haven't learned this yet, but just because they're conscious doesn't mean that they're not really sick or injured. I would take a look at what happened to them. Kids are really good at compensating for their injuries and appearing like they're okay until they can't compensate anymore, and then they crash really quickly. So if I had what I would consider to be a significant mechanism of injury, I want the kid and we're going to go. I can call the parent from the ambulance and say, hey, here's what's happened. We're on our way to the hospital.
Would you feel an obligation to call the parents, or is that just sort of situational?
If the child was able to say, this is who my parent is, this is their phone number, and my hands, we weren't busy taking care of them, and I absolutely would.
Like, would you look for the ICE number on the phone or something?
Yeah, if they had one, absolutely.
Minor is under 18, or what was the age definition for minor?
Under 18. And then the last one is mentally incompetent adults. So adults who maybe are developmentally disabled, who have guardians who make healthcare decisions for them, we would need to contact their guardians. for that to get consent. So confidentiality, everything that we do in EMS, when you think about taking care of patients, finding out information about their health, what happened, all of those things, that is all considered confidential. It falls under HIPAA. And the only people that we can disclose to are those who are in the need to know healthcare wise. So their history, the assessment, whatever I did, I can tell another EMS provider who's coming on scene. I can talk to my crew about it. When I get to the hospital, I can talk to the nurses and the doctors about it. So those are the people that I can tell. In most ambulance, at the end of the ride, we have a patient sign off. We give them information about HIPAA. We can't reveal any other information, right? So when we go back to the station, we're not supposed to talk about it and all that information. If a lawyer comes knocking on the door, because maybe you took care of a patient that was in a car crash and they're going to sue somebody, you're not allowed to disclose any information unless the patient signs a written release. So anything that's healthcare related that your patient has told you remains confidential. You cannot tell anybody else other than those in the need to know.
Chris.
Yeah.
Where does crew debriefing fall on that scale? Like call review at the end of the month or whatever with more than the people who are on that specific call.
Do you mean like a service doing a general call review?
Sure. Yeah.
You can do general call reviews without saying who the patient was.
So as long as you're not using specific patient name or anything like that, you're okay.
Absolutely. Absolutely. You could.
The one thing with that we want to be careful about is, especially with places like Vermont where communities are pretty tight knit and close, is that if you're out at the coffee shop after you just ran a call and you're talking about the call without disclosing a name, but somebody who knows that person said, oh, hey, I know who was actually in that car accident. I just spoke to them on the phone. You've actually kind of broken HIPAA there because you have disclosed information about that call to somebody who knows who they are. So we do just have to be careful.
And some places in Vermont are really small. Like Andrew, you're just because you're in my picture, you're in Shelburne, right? Yeah. That's a nice little community, small, people know people. That could easily happen. Or somebody could come up to you and say, oh my God, Andrew, were you on that call? Tell me about it. Because some people have scanners. So
Happens all the time.
Happens all the time.
We also we use Active 911 up here in the islands.
Yep.
And my chief told us if we have it on our phones to have it password protected, that way someone can't pick it up and then see what's on our phone. That was a really, really good decision or advice from your chief. That is really, really a good idea. So we just have to be.
Just quickly, are there any times with law enforcement where they'll have questions about your interactions with somebody who's involved in, a criminal matter?
Sometimes they might. And again, we have to be law enforcement is very, very good. They know what we can and cannot tell them. And so they understand that anything the patient told us related to their history, that kind of stuff that we cannot tell them. And it can be challenging sometimes. It can be.
Patients are also they can be quite colorful in terms of the scope of things that they say. So if someone were to, disclose to you that they committed a crime or something, I would assume that you'd be free to pass that along.
If it is not related to their history, assessment, or treatment, that one I'm not positive about. Where we sometimes run into challenges, I love to tell this story. 11 o'clock Saturday morning, 70-year-old woman driving home from the grocery store causes a 3-car crash. The roads almost shut down, traffic's backed up. I get there, I'm talking to her. Police officer comes up to me or I'm talking to her and I'm like, I'm like, do I smell alcohol? And so I said, ma'am, I'm like, have you been drinking today? And she said, oh, yes, dear. I said, well, how much have you had to drink today? And she said, oh, what time is it? I said, it's 11 o'clock in the morning. And she had had multiple vodka and tonics. The police officer had already talked to her. And so, she had said she wasn't injured. She was fine. She could go home. And so he came over and he's like, Chris, you going to let her go? Like, we want to get the road open back up. Let's go, let's go, let's go. And I'm like, and I know she's intoxicated. And I'm like, did you talk to her? Oh yeah, Chris, I talked to her. Let her go. We're all set. And I'm like, no, really, did you talk to her? You get to know law enforcement. He's like, oh, Chris, you're trying to tell me something. So he walked over to her and he started to talk to her a little more, got in a little closer. And then he realized it without me having to say. So we have to be very careful. But like I said, law enforcement's very good and they really know what we can and can't tell them. They don't really put us in those kind of positions usually. All right. Assault and battery. So you'd all chuckle, you'd all say, oh, I would never do this to my patient, ever, ever, ever. Except we do. Assault is when you place a person in fear of bodily harm without their consent. And so here's my best example of this. Charlie, you're on my screen, so I'm going to use you. I am taking care of Charlie, and he is not a cooperative patient at all. Total pain in my butt, giving me a hard time, really, like, it's really gutting at me, and now he's just driving me crazy. And so we're getting him ready to go, and he's just being really, really difficult. And I turn to him and I hold up a 14 gauge needle. Now, if anybody has never seen a 14 gauge needle, which I'm guessing a lot of you haven't, it's not a needle that any one of you ever wants to have. It's a big, big, big needle. It's the kind of needle we would use if we needed to massively infuse fluid into our patient and get a lot of fluid into them. It's big.
Nicknamed the garden hose.
There you go. I turn to Charlie with the 14 gauge in my hand and I say, look, dude, if you don't shut up right now and behave and just be quiet and do what we're telling you to do, I am going to stick this needle in your arm. You got it? Well, there you go. Now maybe he doesn't find me intimidating, but if in my true presence of EMS, you would. He feels like, in fear that, this ridiculous woman is going to stick a garden hose in his arm, but I've threatened him. We cannot threaten to harm our patients. The second one is battery, which is unlawfully touching a patient. We talked about this. Remember the other day when we were doing medical assessments and we were talking about the physical exam piece, and I talked about make sure you ask permission before you touch your patients, right? Make sure you ask permission. Hey, are you okay that I check you out? And most patients are going to say yes. But I've seen cases, some of my favorite cases of battery are, you get to a car accident, someone's like, yeah, my neck's a little stiff. And so Kevin says, hey, Nate, I want you to do cervical spine immobilization on that patient. And the patient's like, no, I'm good. I'm not going to go by ambulance. I'm all set. I don't want to go. And Kevin's like, no, Nate, do cervical spine immobilization. And the patient says, look, no, I don't want to go. I don't want you guys to touch me. I'm fine. And then Kevin's like, Nate, I'm the advanced EMT. You do what I say, do it. And so he does it. Well, he touched the patient without the patient said they didn't want it. And you did it anyways. So, and then the last one is false imprisonment. And I already mentioned that right at the beginning. Remember the doctor that told the crew to kidnap the patient? So taking a patient without a competent patient, alert and oriented, not under the influence of alcohol or drugs. So that alert and oriented patient So a patient who can give expressed in consent, if you take them to the hospital against their will, it's false imprisonment. You could be charged. So just keep that in mind. All right.
What do you do if a patient changes their mind on the way to the hospital?
So that's an excellent question. So patients can give consent and they can take consent away and they can consent to certain things. So yes, I will go to the hospital for that neck pain from my car accident, but no, you may not put a cervical collar on me. Document, but they can give and pull consent away. Yes, I'll go. No, you may not do an IV. No, I don't want to take any medication. So they can say what they will and won't have. Once transport has started, a patient can't change their mind and say, oh, you know what? I think I'm good. Why don't you just let me out at the street corner? And if you don't think it happens, one time I picked up a patient who was out in Charlotte, who wanted to be in Burlington. And as soon as we got to Burlington, he's like, you know what? I've changed my mind. I don't want to go to the hospital. Why don't you let me out at the corner? Can't do that. So once the transport is started, there's no letting them out. Just take them to the hospital and just tell them, look, we have to take you now. If you decide you want to check out before before the doctor sees you, you can tell the hospital that and you can check out AMA. But once you've transported, the transport's going to happen.
And,
all right.
And
Go ahead.
what if they start to become violent and like start causing a ruckus in the back?
Also has happened.
Yeah, they're kind of trapped there with a loud person.
Pull over and call for assistance because it's not safe to be in a moving ambulance with a patient that is dangerous to you, a threat to you. So refusal of care. So as I've already said, patients who are alert, oriented, fully oriented adults, not under the influence or not significantly impaired, they have the right to refuse care. They have the right to withdraw from care. But this is the call that we really have to document well, especially if we think the patient needs to go. A patient has a right to say, I don't want to go, even if we really think that they should, even though medical direction thinks they should. So we really have to document it very, very well. And right before we go, I'm going to show you a refusal of treatment form, but it has to be documented. And then the last one, advanced directives. So patients have, so a DNR, I mentioned that, or someone brought it up earlier. DNR just means do not resuscitate. It's paperwork. It's signed by a physician, and a patient spells out ahead of time because whether they're elderly, whether they have terminal illness, whether they just have, all other illnesses, not necessarily terminal, but people make decisions ahead of time. If I go into cardiac arrest, do not resuscitate me. But again, that's all it means. Do not resuscitate. That's all a DNR means, is do not resuscitate if they go into cardiac arrest. You need to see the paperwork. So you have to see the DNR paperwork. If they don't have it, that you need them to produce it, or you need to call the hospital. But if it's in doubt, start resuscitative efforts, start CPR. If you don't know about a DNR, you think there's one, but nobody has a copy of it, nobody can confirm that there's one. If that patient goes into cardiac arrest, you must start resuscitative efforts.
If the patient has a health proxy there, can they make a verbal DNR request?
If they have a proxy who has power under advanced directives, have been appointed, their medical power of attorney, yes. But
So they
again,
would need that paperwork.
you have to see that paperwork. So I know we're running right up to 8:30, so I'm going to stop sharing because I just want.
Yeah. I don't know if it's out yet or anything like that, but isn't there different levels of DNR for like not to use machinery and
Yep, that's exactly what I was going to show you.
Perfect.
So hang on one sec. Kev, do you see the refusal of care? Yeah, okay. So just really quickly, when you are having a patient that is a non-transport patient, you need to fill out a state refusal of care form, where you just go through and fill out all these check boxes. And basically, as you go through this refusal of care, the top of it looks like this. Anything that is a gray box, where you see all these grays, anything that is a gray box requires a phone call to medical direction before you can terminate, before you cannot transport that patient. So that alert and oriented patient who is having chest pain and recognizes they could be having a heart attack, but doesn't want to go, that's a gray box. You have to call a doctor. That really intoxicated patient that doesn't want to go to the hospital, they seem like they're okay, but they don't want to go, it's a gray box. You have to call the hospital. Any gray boxes. And if you're with a service, your service is carrying these. They're in the clipboard, and anytime you non-transport a patient, this needs to be filled out. And it's signed at the bottom by the patient, by you, and by a witness. So this paperwork has to be filled out. And then the last piece really quickly is this is the form you're talking about, Nate. So this is a brand new form. This just went into effect June 1st of this year. This is the Vermont DNR COLST form, and COLST is clinician order for DNR or other significant, other life-sustaining treatments. So this is the form that includes a DNR and advanced directives. So not just to do not resuscitate, but in the event that I'm unable to make decisions for myself, these are what I will spell out. So DNR is right at the top, right at the top. No CPR, do not attempt. Yes, do CPR. And if they want CPR, they get everything. And it's got to be signed by the patient, by a doctor. Then as you go down, it becomes those other advanced directives, whether they'll be intubated. So no, don't intubate me. I'll do a trial course of, or yep, make sure you intubate me, do everything. Patients can check off whether, they'll have sustaining life, what interventions they'll take or not take, whether they just want comfort care. This is all spelled out in a form, whether they will take nutrition, whether they will take hydration, and other things that they can spell out. This is that advanced directive form that you were asking about, Nate. It's a brand new form, just came out. We've had it for several years. When I say it's brand new, it's just a new version that makes it easier for EMS providers to read. All right. Do folks have any questions?